प्रणव सर, आपको कंडोलेंस भी 1-2 मिनट का करवा लेना होगा बैठ
हाँ
करके।
हाँ, नहीं नहीं, वो तो शुरू में करवाना है नागेंद्र। वी स्टार्ट
हाँ,
ऑफ
हम
द
बोल देंगे।
कंडोलेंस, वो हम पहले ही लिख चुके थे। बिफोर यू मेंशन दैट वाज इन माय माइंड कि उसको कर देना शुरू में।
वेलकम के बाद ना सर कंडोलेंस कर देंगे,
हाँ, वेलकम के बाद,
तो सुनील के बाद कर देंगे।
सुनील के बाद, इमीडिएटली सुनील के बाद।
आई थिंक कंडोलेंस सबसे पहले होता है क्या?
नहीं, पहले वेलकम कर लो सो दैट पीपल असेंबल एंड देन वी डू द कंडोलेंस।
यस यस यस।
So we are live.
We are live, sir.
So can we request Dr. Sunil Singh to give the welcome address? Dr.
Good evening, everybody. Nagendra, would you like to say something, or as we start?
Yeah. At the outset, I like to welcome you all in this meeting of the BOSS ARC. It is done for the PGs, and it is done by the PGs only, for and done both. So, and I would like to welcome Dr. Pranav Ranjan sir, Dr. Vibhuti here. He is our secretary. Pranav sir is his treasurer, and Dr. Sunil, who is going to address welcome address, and he is ex-secretary and senior member of the academic research committee. We have chairperson here, Dr. K.S. Gupta, Dr. Atul Mishra, Dr. Pradeep Karak, and Dr. Ajay. And we have a list of panelists, Dr. K.L. Agarwal, Dr. Ajit Dwivedi, Dr. Abhishek Ranjan. There is slide change. Rakhi is not able to join right now. And I would like to welcome Dr. Salil Kumar Mandal, who is a professor of ophthalmology. I would come while delivering his keynote address. We have a galaxy of speakers, young speakers, Dr. Nandan from Bhagalpur, Dr. Pragati from RIO IGMS, Dr. Farhat from NMCS, Dr. Ashif and Ali Kaisar from DMCH, and Shreya from PMCH. Dr. Asif topic will be delivered by Dr. Ali Kaisar. There is slight change on this here. Now, now I request Dr. Sunil Singh to welcome to deliver a welcome talk for the encouragement of the younger generation.
Thank you, Dr. Nagendra, who is chairman of Academic and Research Committee of Bihar Ophthalmological Society. And at the outset, I would like to thank Bihar Ophthalmological Society ARC committee to give me an opportunity to welcome you all. So on behalf of BOSS ARC committee, I welcome you all. So especially my president sir is there, the secretary Dr. Vibhuti, who is also director of IGMS, is there. And immediate past president Milind sir is there, Dr. K.S. Gupta is there, Dr. K.L. Agarwal. Dr. K.L. Agarwal is there, Dr. Nandan Kumar, Dr. Salil Kumar Mandal, who will be giving a keynote address, Dr. Abhishek, Dr. Ajay Sinha, Dr. Farhat Parveen, Dr. Shreya, Dr. Ali Kaisar. And on the behalf, I would like to, and the moderator is Dr. Nagendra, like I said, the chairperson, we have a galaxy of very good chairpersons like Dr. K.S. Gupta, Dr. Atul Mishra, Dr. Pradeep Karak, and Dr. Ajay. And the panelists are, I again welcome the panelists also. Dr. K.L. Agarwal, Dr. Ajit Dwivedi, Dr. Abhishek Ranjan, Dr. Rakhi Kushumesh, and again welcome Dr. Salil Kumar Mandal, who will be giving a keynote address with a professor of ophthalmology, and on the topic will be blunt ocular trauma. The galaxy of speakers, I welcome the galaxy of speakers also on behalf of BOSS ARC committee, Dr. Nandan, Dr. Pragati, Dr. Farhat, Dr. Asif Sahnawaz, Dr. Ali Kaisar, Dr. Shreya. I welcome you all and all the audiences and the esteemed members of the Bihar Ophthalmological Society. We welcome you all. And this is our ARC committee, like Dr. Nagendra said, who is our chairman of ARC, that this is for the PG, by the PG, of the PG. So all the PG will be giving a talk, and I really say the topic is very relevant of the blunt trauma. And again, on the behalf of BOSS ARC, I welcome you all. Let's start. We'll not taking much of a time. And over to moderator of Nagendra.
Thanks, Dr. Sunil, for your welcome message. Now I request Dr. Pranav Ranjan, because today we have lost one of our senior member, Dr. Ahmed. So in his memory, I request Dr.
Doctor, we got an information about demise of Dr. Laik Ahmed. He was a very senior BOS member, and he used to do his practice in Patna city area, as well as he was associated with a charitable hospital in Danapur. He worked along with Dr. Parasnath Sinha. He was the batchmate of Dr. ASB Sahai and Dr. Riyaj Hassan, late Dr. Riyaj Hassan. So today we got the information about his demise, and in respect of the departed soul, I request everybody to stand up wherever they are for 1 minute and stand in silence and pray for the departed soul. So please. So with this, we break our morning and prayers and get back to the proceedings of the webinar. So
Okay,
Dr.
thank you,
Nagendra,
sir. Thank you, sir. Now I request you to say a few words of encouragement to the youngster, sir.
anybody would like to speak about Dr. Laik Ahmed before I say 2 words? Okay.
Not any interaction.
Okay, right. So most of the people, because he was so senior that most of us we have only heard about him. Even I have not personally met him, but when I was working in Danapur Charitable Hospital, I used to hear about him, about his philanthropy, about his clean heart, about his upright approach, and about his surgical skill. Everybody used to praise him like anything. So a great soul, a great BOS member, and a great person we have lost today. With these few words, I would once again welcome our invited speaker who is going to give the keynote address, Professor Salil Kumar Mandal from Calcutta. A warm welcome to you from our BOS family. Welcome to our chairpersons, the panelists, the speakers, Dr. Sunil Singh and Dr. Nagendra. Both of them have already mentioned their names. I'll not mention them again. And we are looking forward to a very, very bright and interesting interaction. I must also applaud and appreciate Dr. Nagendra Prasad, the chairman of ARC, along with the members of ARC, especially Dr. Sunil Singh, Dr. Milind, immediate past president, Dr. K.S. Gupta, Dr. Pradeep Karak, Dr. Jai Gopal Agarwal, Dr. Vibhuti Prasanna Sinha, the secretary and now the director of IJMS, Dr. Satyajit Sinha, chairman scientific committee, Dr. Nilesh, treasurer, Dr. Ranjana, a special mention about her effort in bringing the journal to a higher level and getting it affiliated to a publisher, Walter Kluwer. So congratulations to her and all the executive members who have extended their wholehearted support in making BOS and the academic front of BOS shine like chips of frozen fire. We are today meeting to deliberate on a topic, ocular trauma. Ocular trauma perhaps is one of the most common subject which is encountered by almost every ophthalmologist. So it is going to be a very, very interesting deliberation, and best of luck to all the persons involved in today's deliberation. So let us enjoy that deliberation. Thank you so much. With these few words, over to you, Dr. Nagendra.
Thank you, Pranav sir, for your word of encouragement, and it is a great day for history of BOS. As editor, Dr. Ranjana has signed with Walter Kluwer for the proceeding for the journal to the bigger platform. I welcome Dr. Ashif Sahnawaz, who is going to the panelist of this session, Dr. Ashif, and I request our secretary, Dr. Vibhuti Prasanna Sinha, who is the director of IGMS also, it is honorable for us and to speak few words. Dr. Vibhuti, over to you.
Thank you very much, Nagendra sir. First of all, let me pay my homage and condolence to the bereaved family. And we all are saddened by the untimely demise of Sir. Today's topic is one of the topic which hits everyone in our day-to-day practice, and more so it is important for the postgraduates to understand the presentations of these cases. I know Sudhir sir is involved with in selection of these cases and formulation of this webinar. So like him, this is going to be an interactive session, and even I'm going to learn few new things about trauma tonight. So I just welcome you everyone. Welcome to the guest speaker, Dr. Professor Salil Mandal. And over to you, Sir Nagendra sir, for tonight's deliberation. We are going to learn a lot from tonight's deliberation.
Thanks, Dr. Vibhuti. It is the whole subject is conceptualized by Dr. Sudhir, and he only coordinated the rest of the speakers from. So I big thank you, Dr. Sudhir, for helping us. And it is a basic, because you are the member of the ARC, so it is your job also to help us. So now I would like to welcome Dr. Salil Kumar Mandal, if he is going to deliver keynote address on blunt trauma, ocular trauma. Dr. Salil Kumar Mandal passed MBBS from Calcutta, RG Kar Medical College, MD Ophthalmology from the AIMS Delhi, and DNB Ophthalmology New Delhi, and he has received Best Video Award from AIC in 2020 and Best Physical Poster Award AIOC 2021. In oculoplasty. He also received Best Free Paper Oculoplasty 2019 in Delhi Ophthalmological Society, and Best Video Award category, Best Video Award Surgery, Best Video Award for the Cataract Surgery in DOS 2020. And his paper has been selected as the second best free paper in oculoplasty in 2020. He is a professor of the Department of Orbit and Oculoplasty in RIU Medical College, Calcutta. He has 30 publications under his name, and he is a reviewer of the International Journal too. And he represented 4 times in ARVO USA. So with this word, I welcome Dr. Salil Kumar Mandal, sir, to deliver his talk on blunt ocular trauma. It is honorable to have you here in this platform, sir, for the encouragement and for the enlightening the topic to the general ophthalmologist, and particularly those who are going specialist practice. Dr. Salil.
It's a pleasure to me for inviting me for Bihar Ophthalmological Society to speak on a blunt ocular trauma. My slide is visible?
Yes, sir.
Hello?
Yes. Can you go to slideshow?
It's a pleasure to see that the Bihar Ophthalmological Society invite me to speak on a blunt ocular trauma. Firstly, my respected senior, my junior, my colleagues to invite me to the Bihar for deliberating the blunt ocular trauma. The blunt ocular trauma is the most important subject in emergency as well as in routine management. No pertinent conflicts of interest to disclose.
Slideshow, please, sir. Go on slideshow mode, sir.
It's not moving. Blunt trauma is a specific injury.
So just click on the screen, the slideshow screen. You put it in slideshow mode, sir.
It is in slideshow and changing the slide on a cursor. Specific injury, the blunt ocular trauma. First comes with the examination part, approach to the patient, examination technique, external examination, examination of face and lids, and examination of the visual acuity, pupillary status, extraocular motility, visual fields, and ocular motility, and extraocular and anterior segment examination like a conjunctiva, cornea, anterior chamber, iris, and lens, and vitreous body and retina.
Are not moving. May I interrupt you? Person from
determination.
can you help him?
So he will
Determination,
help.
determination of blunt trauma, amount of energy transferred to the globe and orbit, which depends on the physical character of the object, that is density, size, sharp, and cutting edge. The vector
Dr.
force
Salil,
which
sorry
generates.
to interrupt you, Dr. Sunil. It is slide is not moving, so please, I request audiovisual Zoom people to help him.
Yes, the slide is moving in my
Sir, can you
computer.
Sir, can you stop the share for a minute, sir?
Can you share it again? I suppose if we can share it again.
Yes,
probably
just
start working.
just stop the share, sir.
Now it's visible.
No, sir.
Sir, you will have to click on the resume slideshow if you can. Hello.
Hello.
Just click on the resume slideshow, sir.
That is also resume share. Resume share. Now
Resume share.
it is visible.
So you will have to first stop and then reshare. It is not coming. Only one slide is coming. We can see your arrow moving. There is a small icon which says resume slideshow. Sir, ये ऊपर
Yeah,
जब blunt
yeah.
trauma के ऊपर blunt trauma के left hand side पे sir.
Left.
Just on the left of the
Slide, sir.
Here.
Yes. Left. Again go left.
more left. Yeah.
Yes.
Yeah.
Click it now.
Now it's visible.
Visible, it is visible, sir, but slide is not in the slideshow mode.
Better you off, then again start.
Now it is changed.
No, sir.
I-
nothing.
No.
It's not changing. I think you can stop the share and then
Stop sharing, huh?
I-
Stop
I've
sharing
stopped.
and share again.
Share
Sir,
again.
I've stopped. Can you just stop, reshare it now, please?
Welcome, Satyajit.
Thank you, sir. Thank you.
कहाँ है सजीद है कहाँ ये तो पता लगाओ.
आवाज ही काफी है उसका.
वेलकम सत्यजीत. कहाँ है? आउट ऑफ स्टेशन की कहाँ?
बैरिस्टर
Can you-
बैरिस्टर में बैठा हुआ है.
Sir, Dr. Salil,
भीमसरिया
can you
सर के
just start
बाद
now?
भीमसरिया सर के बाद सत्यजीत का ही हंसी फेमस होता जा रहा है.
Now slide share again, sir. Dr.
Dr. Salil, just do the share again, please. Just click on the share screen button and on the pop-up, just do the share again.
Alt cap.
No, just on the Zoom window, there is a share screen button 6 o'clock. उस पे क्लिक करिएगा, पॉपअप आएगा और राइट हैंड साइड पे ब्लू बटन होगा, शेयर उस पे क्लिक कर दीजिएगा. Dr. Salil, can you hear us?
Yes. It's a problem for participant. Can
Okay, just go to the slide share. Yeah, slide share. The button.
Resume slides now again.
सर अगेन ऊपर टैब जो रिज्यूम स्लाइड शो है उस पे क्लिक कर दीजिए.
now it is visible.
नो सर, यू विल हैव टू क्लिक ऑन द रिज्यूम स्लाइड शो जो आपको पॉपअप आ रहा है
Yes.
इस
Yes.
पे.
Now it's visible.
नो सर,
Click it, sir.
सर उस पे क्लिक करने का है रिज्यूम
Tab.
स्लाइड शो पे या ऑल्ट आर दबा दीजिए अपने कीबोर्ड पे. ऑल्ट आर.
It's visible.
No sir. So I think there is some problem with your PowerPoint.
I have been seeing.
Sir, you can do one thing. You can click on individual slides and then you can present, sir. Like 1, 2, 3. I mean, click on the individual slide and then you
Yes.
can continue.
That's rather good.
Yeah.
Click it now.
Yeah. You keep clicking and then
Yes.
This
Yes.
is,
That's
Uh,
good. It will go.
yeah, this is working.
Will go.
Yeah. So now we can continue with this.
Yeah, sir. Yeah, history
Yes.
of events from there.
History of event. If the site is visible, just tell me. Otherwise, it's.
No, now it is. It is.
On clicking,
you'll have-
sir. On
Yeah,
clicking.
you have to click on the slide.
Okay.
It is visible.
Okay, right. Now here is the determination of blunt trauma, amount of energy transferred to the globe and orbit that depends on the physical character of the orbit, the physical character of the object. The physical character object it depends on the density, size, sharp, edge and cutting edge, and also the vector and vector force or quantity of the force generated by the impact. Location of the impact is very important, whether it is in the lateral area or the floor of the orbit. Examination of face and lids. Active bleeding should be controlled with tamponade and unclean the normal saline. If possible, lid should be evaded. Examine the lid full thickness and lid wingy. Depth extent of skin should be clearly noted. Subcutaneous emphysema in the conjunctiva indicated fracture, orbital bone and sinuses, and face, head, neck injury should be noted. Abnormal positional lid noted. Examination of the ptosis, LPS action, palpebral fissure height, and auscultation of the closed lid. Sometimes the blunt trauma may cause as a carotid cavernous fistula. This is a photograph. This is a marginal laceration involving the upper and lower lid and the medial canthal injury. It is just restoration of the normal anatomy and repair it. Assessment of the visual acuity, the baseline visual acuity is essential. It may deteriorate in progressive intraocular hemorrhage. Near vision card is sufficient for checking the visual acuity and pinhole for distant vision. Optic nerve contusion and traumatic retinal angiopathy may cause a fluctuation of the visual acuity. No perception of light documented carefully. Imaging, diagnostic imaging of the ocular trauma is very important. The modalities are plain film, computed tomography, ultrasound, magnetic imaging. Plain film is still as an important. Caldwell will vertex view and lateral position. These are help to detect the trauma, a fracture, or the foreign body inside it. CT scan is standard diagnostic imaging in a traumatized patient. All the view, axial, coronal, and sagittal view is important to accurate anatomic view of the soft tissue and bony changes resulting from trauma. Exact extent of the orbital wall and soft tissue incarceration is better seen in CT. Current generation machines also detect a 1 millimeter size, say, foreign body, except the aluminum. And also thinnest possible slice may be application for 1.5 millimeter size for better detection of the foreign body as well as the fracture site. Ocular VSG performed with 8 to 10 mHz, which is for anterior chamber pathology and the posterior segment pathology, to rule out the lens dislocation, vitreous damage, PVD, and RD. MRI is a limited use. MRI for non-metallic vegetative glass, a plastic foreign body, and localization of the orbit. It is useful in post-operative evaluation of the globe. This is a CT scan which shown the infraorbital feature of the metallic foreign body, and this slide shows the fracture at the means the inferior wall of the orbit, which fracture the middle wall of the orbit with the ear inside the globe. This is a USG which shows the anterior chamber hemorrhage, or called the anterior traumatic hyphema. Orbital and additional trauma, edema, emphysema, hemorrhage, ophthalmology is all due to a trauma. It may cause stosis, optic nerve blindness, and persisting conjunctival prolapse. This all patient, when it develops the edema, emphysema, hemorrhage, we have to retract the eyelid and examine some of the eyeball and cornea to see the corneal perforation or a globe rupture is there. The treatment is corticosteroid, orbital cellulitis. If it's expected, then you can do an antibiotic. Intraocular pressure better monitor. Surgical procedure, lateral canthotomy when you suspect the intraorbital pressure is increased. Sometimes we do that decompression after lateral canthotomy for the excision of the orbital septum to drainage of the blood, and negative suction used for surgical decompression of the hemorrhage in the orbit. Sometimes peritomy may be done due to persistent conjunctival prolapse. Antersegment trauma, conjunct with the first line of defense for blunt ocular trauma, subconjunctival hemorrhage is observed, better absorbed. Subconjunctival emphysema, cystic appearance of the conjunctiva, stroma, cavities in the palpation, commonly associated with the sinus fracture or fracture in the lamina papilla ethmoid. Simple multiple point in the conjunctiva can be seen. Sometimes conjunctival laceration with broken glass sometimes be seen. In the absence of globe rupture, small conjunctival perforating injury better not to repair. Defect larger than the 1 centimeter sutured with absorbable material. Congenital laceration with, this is a photograph, this conjunctival laceration with subconjunctival hemorrhage. This is the foreign body of the conjunctiva. which is seen in the bulbar conjunctiva. Corneal penetration is suspected, then you do a Siddle test for aqueous leakage. Corneal abrasion caused by direct tangential impact of foreign body by fingernail, plant, mascara, brass, and contact lens. Careful examines the bulbar and tarsal conjunctiva for foreign body. Significant risks of microbial infection when there is a vegetative trauma. Topical anesthetic better avoided. It may cause a delayed wound healing. A recurrent irritation of persistent epithelial can be managed efficiently. This is a corneal perforation injury, which is repaired efficiently with AC formation. Pupil and iris, unconscious patient, pupil reflex is the only indicator of the visual system function. The pupil should be inspected, shape, location, light reaction, and eccentricity. Dilated pupil in the presence of head injury is a sign of increased intracranial pressure. Significant blunt trauma initially people has a spasmodic miosis, which is transient accompanied by a spasmo accommodation, followed by traumatic mediasis, which is loss of accommodation. Picked people is worrisome. It may be indicate intraocular hemorrhage and scleral corneal perforation. RAPD always evaluate in all trauma patients. In iris injury, mostly penetrating injury and non-penetrating also. The most common pattern of iris injury is the sphincter tear, dialysis of most of the iris root, iridialysis, iridoschisis, and iris atrophy because of vascularity problem. In the blunt trauma, the pigment liberated from the iris is deposited in the cornea, endothelium, and trabecular meshes causes transient glaucoma. Initially, sphincter muscle injuries minimally resulting in anisocoria, and also in severe cases, profound mydriasis followed by unresponsiveness to light. Stretching of the iris root, frequently in the hyphema, hyperpigmentation at angle or synechial formation. There may be angle recession, dialysis of the iris root, and creation of the cyclodialysis clip. This is a blunt trauma resulting in iridialysis. This is a iridialysis. It requires sutures. We put a mechanical suture and repair it. And there is a iris prolapse, which is repaired urgently if it is a long-standing abscission of the iris done, or excision followed by reposition. Anterior chamber traumatic hyphen is a common manifestation of blunt trauma, stretching of the limbal tissue, equatorial scleral expansion, posterior displacement lens iris diaphragma, acute elevation of IOP. Most of the hyphema due to the injury of the major arterial cycle and the choroidal arteries and ciliary body vein. 15% for the rupture in the iris vessel and cyclodialysis or iridialysis. Microscopic hyphema is better prognosis. Angle recession is the separation between the longitudinal and circular muscle fiber of the ciliary body seen in traumatic hyphema. Amount of angle recession does not correlate to the size of the hyphema or IOP. Indication of surgical intervention of traumatic hyphema, traditional IOP more than 50 mm mercury for 5 days, 35 mm mercury for 7 days, corneal blood staining, a prolonged clot duration, larger clot persistent for more than 10 years, may require urgent drainage. Complication of the long-standing hyphema causes bleeding when it is evacuated, glaucoma, and corneal blood staining. This is a hyphema. This type of hyphema is easily resolved, but this is an 8-ball hyphema. It needs a drainage procedure. Traumatic glaucoma, 7 ring of circle of tissue anterior to the equator suddenly expand. This forceful expansion may cause a tissue separation, resulting in splitting and tearing of the tissue. Such injury in the long term leads to glaucoma. The 7 anterior ring number 1, sphincter pupil, rupture and radial tear. Ring number 2, peripheral edges of the iris base iridialysis. Ring number 3, anterior ciliary body angle recession may produce. Attachment of the ciliary body to the scleral spine. Ring number 4, a cyclodialysis produces a cyclodialysis clip. Number 5, trabecular meshwork, splits and separation of the tissue. Number 6, genular dialysis causes subluxation, dislocation of the lens. 7, attachment of the retina to ora serrata. These are the 7 ring. Just schematic. This is a ring number 1 in the pupillar margin. This is ring number 2, iridialysis. This is ring number 3, angle recession. Ring number 4 is cyclodialysis kept here. Ring number 5, a trabecular meshwork. Ring number 6, a genular dialysis. Ring number 7, the ora serrata. You should remember the picture, then you can assess how the traumatic glaucoma is produced. Acute glaucoma without hemorrhage. Chronic glaucoma with angle recession. If more than 180 degrees the angle is recessed, there is 10% of chance of development of chronic glaucoma. Immediate gonioscopy not required, only for the research purpose. This conioscopy only for research purpose, immediate conioscopy not required. This picture shows a wider ciliary band, trabecular pigmentation, scleral span, and Solbach line. This unexpected wider band may cause as angle recession glaucoma. This is a cyclodactyl cleft, an unequal depth of the anterior chamber, which is shown in the picture. Lens injury, vosseous due to blunt trauma to eye, and circular ring, which is brown amorphous granules of pigments deposited over the anterior lens capsule, same diameter as the contracted pupil in iris imprint due to forced concussion injury. Contusion cataract may be focal, sectoral, or total. Dislocation of the subluxation lanes, rapid equatorial expansion of the globe, second to the sudden anterior posterior compression during blunt trauma can be causes jugular disruption. This is a lens dislocation or subluxation. Age is seen, and this is a vosseous iris imprint of the anterior capsule. Now comes to posterior segment, which is very important. In cope injury, the local trauma is directly at the site of blunt impact. A contra-cope contusive damage occurs on the posterior side of the impact. The retina is vulnerable for contra-cope injury. Blunt ocular trauma, anteroposterior compression, horizontal displacement of the eye fluid, eye expanded the horizontal plane, several posterior segment structures severely stretched. Common commercial retina, first described by Berlins in 1873. Immediate diminution of central vision, retinal clouding, and return of the visual easily. This is a Berlin's edema, whitening of the retina, well-demarcated vessel seen, and ill-defined margin. And this is a scleral rupture, a choroidal rupture associated with the chromosia retinae. Prognosis is fairly good in chromosia retinae. What is that? A geographic pattern of gray-white clouding, opacification of the outer retina. Margins are ill-defined on contact lens biomicroscopy. Inner retina blood vessel clearly visible. Hedge of edematous swelling in the outer retina. Edema may be in the macula, in the posterior hole, and the retinal retina and the peripheral retina. There may be subretinal, interretinal, periretinal hemorrhage, choroidal rupture, and serous macular detachment. Retinal whitening subside within weeks. Partial and full thickness macular hole can be seen. Partial retinopathy is 1912. Partial retinopathy is described in a traumatic patient, and fundus changes dissolve within 4 months. Possible mechanism of arterial occlusion by ER and fatty embolism. Retinal vessels will trauma by increased hydrostatic pressure. Arterial endothelial damage with increased arterial pressure. Local retinal vascular coagulopathy and retinal angiospermic lesion following the increased venous pressure. So this is a picture of partial retinopathy. This is the patchy white and clear vessels are seen, and the retina is mostly developed after a blunt trauma. Now comes to traumatic macular hole. 1869, Knapp described the macular hole by contusive ocular injury. Possible mechanism of post-contusion necrosis of the tissue, subfoveal hemorrhage, and vitreous traction. Vitreous base avulsion, a pathognomonic in the trauma. Retinal dialysis without retinal detachment, 66% in the inferior temporal quadrant, 14% the supranasal, 10% of the supratemporal quadrant. This is a picture of the macular hole, which is seen. Now, retinal dialysis with regmentation retinal detachment, traumatic retinal tear without retinal detachment, traumatic retinal tears with retinal detachment, giant retinal tear without retinal detachment, retinal tears extending more than 90 degrees, all 3 kilocards are commonly known as the giant retinal tear, and with a circumferential globe and giant retinal tear with retinal detachment. Now, this is a picture of a traumatic retinal tears, and this is a giant retinal tear which is crossed over 3 clockwards, and this is a retinal dialysis at the retina, at the oris serrata. Now comes to an optic nerve injury. This is a very common direct trauma to the penetrating injury to the orbit, and avulsion of the optic nerve completely or partially in severe trauma. In severe cases, hole in the posterior sclera often seen where the optic nerve is attached, where the retina attached and supposed to be seen. Blunt trauma, forehead, bow may cause a direct injury to the intracanalicular part of the optic nerve. This is a picture of the optic nerve avulsion at the posterior pole, and optic nerve is out of the sclera, and it's a hole is visible seen. So my recommendation is that when the traumatic patient comes to you, you may not be a specialist. As a general ophthalmologist, you can do as much as possible. After that, when you see it requires a retina specialist opinion or a glaucoma specialist opinion, you clearly send the patient to a specific specialist like retina and a glaucoma. I am basically a plastic surgeon and oculoplastic surgeon. I can manage the treatment of adnexial trauma and lead management. Thank you for attending this session, and thanks to Bihar Ophthalmological Society to invite me to speak over the blunt ocular trauma.
Thank you, Dr. Salil, for your excellent presentation on the ocular trauma and overview of the ocular trauma. And we can get all sort of clinical signs in trauma, and it is very difficult to manage. One thing I would like to stress upon that once you examine the patient, as Dr. Mandal has told, that you always keep in your mind the 7 rings of ocular trauma, so you can't miss the major blunder part of the trauma. And I also, is there any role of a special taking consent before going for the special consent for in those cases? Informed consent should be taken in those cases.
Actually, in emergency situation, I think the special consent is not needed. So first to save the life patient and your management to the visual improvement. And if you do a oculoplasty, then if you do it oculoplasty, you should explain the prognosis of the patient to the party and visual outcome and aesthetic outcome. Especially fully explain to the patient party that I have do what is my best and possible outcome like this. You should be clearly mention the visual acuity. Patient may be blind, but don't say unnecessary the patient can be see everything. So blunt ocular trauma is very important. Prognosis should be clearly explained to the patient party, and otherwise they have a misinterpretation. If you repair a corneal injury, you should say 6/6 vision, it is not possible. So clearly mention clearly before on the next day after operation that this is your visual outcome.
Very pertinent point, Dr. Salil. Any panelist wants to add something?
Just one thing, Dr. Sudhir, you continue, Dr. Sudhir, then I'll ask you.
Actually, I want to highlight 1 or 2 things regarding a blunt injury. Patient may look normal in the first view, and you may say that you don't need any consultation or any ophthalmic intervention. But one should be calm, especially in the emergency. The PGs are there, and they should see the visual acuity. The visual acuity may be good at the time of presentation, but later on, when the cataract, if he is having, this will increase with time in a day or 2, and the patient may see poor vision or decreased vision. Then they may blame you for your treatment. So one should always say that at this moment, this is your condition, but let the time pass and hope that you will be good with future. But the things may appear, worse things may appear in coming days. So don't explain the visual prognosis in a very good term, but rather say that let us see what happens to you. And obviously, Dr. Salil has pointed out that the patient may be having glaucoma, or he may develop glaucoma apart from other trauma or retinal detachment or vitreous hemorrhage, because these may be basically these may get obscured behind the hyphema in the anterior chamber. And so all these should be explained, and rather before explaining, the postgraduates and the residents there must look for any injury which can cause further damage to the eye and prevent those injuries. Thank you.
Another one thing, Dr. Salil, can I ask one question? Dr. Salil,
yes.
You were saying the protocol about the hyphema, when to give medical management, when to drain, and if after drain it again reappears, pressure is raising, when to do what? Can you elaborate on that?
Actually, the hyphema if it's a micro circulation hyphema, it is spontaneously drained. Some of the patient I have seen that there is a rebleeding. There might be a chance of blood coagulopathy. You should check for BT-CT platelet count. You can try it. Rebleeding maybe happen. The most of the injury from the major arterial circle, and if it is not tamponed properly, it will again rebleed. A sudden sudden pressure fall down in the anterior chamber, again it may causes rebleeding. So before evacuation of the hyphema, you should tamponate with the ER. If you take the full ER chamber, chances of rebleeding is less. This is my experience about that.
Sunil, when to drain and when to wait for the drain or give medical management? When
that
to
I
drain
have
and
seen
when not to
when
drain?
to drain, that I have seen that when the pressure is more than 50 millimeter mercury for 5 days and 35 mercury for 7 days, this is the indication. And if the patient have a corneal blood staining, you should urgently drain it. And again, there is if there is a persistent clot retraction is there, this clot is never absorbed. So if the clot is there more than 10 days, you should remove that clot. Otherwise, patient is difficult to see it, and lots of complication lateral may cause posterior synechia, glaucoma formation. The hyphemas, when you see more than 5 days, and the criteria I have seen, I have told before that if you not maintain, then you will be in problem. So protocol should be maintained to prevent your medical importance. So nobody have a question that why you are not doing an hyphema drainage. So according to book, we are doing the hyphema drainage.
Thank you, Dr. Salil.
Dr. Ajit would like to add something. Dr. Abhishek, please.
One thing I want to add that sometimes ocular trauma, in case of ocular trauma, subconjunctival hemorrhage should be looked for very cautiously, because sometimes a scleral rupture is there behind the subconjunctival hemorrhage that is concealed. And if we suspect like intraocular pressure is slightly lower side or whatever, then we have to explore the wound, and we should rule out any concealed scleral tear. And one question I want to ask one question from Dr. Salil, that in CT scan all the metallic foreign bodies are detected, but why aluminum is not detected?
Actually, it is written in a book. So aluminum is not detected in CT scan. I have written in a book, but rest of all the metallic foreign body is seen in CT scan also. So what about the aluminum foreign body is a real foreign body in the orbit. I think this go for magnetic resonance imaging when the CT scan is not performing the detection of this non-metallic, this metal, a low dense ecocity. So advice for MRI, because I am also not clear whether it's in aluminum foreign body impacted in the orbit, how will you detect? It may be a MRI or a CT, but CT is not detected, that I know, but I have read from the book.
So actually, in any type of foreign body, ultrasound is one of the good indicator, because CT scan has very limitation of its thickness. But while ultrasound can pick a smaller metallic or non-metallic foreign body. And regarding aluminum, if it is pure, really I heard it for the first time that it is not detectable on CT scan. And probably nowadays aluminum in pure form is not used in industrial or home appliances. They are usually mixed with some other alloy. Yeah, they are formed in. Anyway, it is information for me. But ultrasound is a good alternative before you go for MRI, because this will give better resolution of the foreign body, even if it is non-metallic.
Sir, it was such a very nice overview of the blunt ocular trauma by sir, and it was all the things we should keep in mind. I just want to highlight two things. Whenever an ocular trauma patient presents to us, they present in two scenarios. Either the patient come to us or we go to the ICU to detect there. So even in ICU, even in ICU, we should be very much careful about the pupillary reactions and the prognosis. And if you will be able to diagnose those optic nerve avulsions or suspect even those optic nerve avulsion, many a time the anterior segment is okay and the posterior segment you may find with them. And the mere addition of steroids along with consultation with the neurosurgeon, we can do wonders. And definitely Dr. Abhishek has highlighted that any trivial trauma to the globe should be suspected and must be examined in detail, definitely on another visit.
Very nice input, Dr. Ajit Dwivedi. And if
Just
anyone
to add on one word, sir.
Yeah,
Apart
Dr.
from all
Nilesh,
these
welcome,
things,
Nilesh.
I would just emphasize that having said everything, the documentation must be very meticulous in these trauma cases, because these cases usually later on turn out to be medico-legal, and that point of time, if things are not very well documented, but I want to emphasize the importance of documentation in ocular trauma cases. That should be done.
नीलेश तुम हो कहाँ हो, क्या कर रहे हो नीलेश?
If you go in history,
Sir, वो
history is
बाहर
very
है, टहलते
important
हुए आ
in
रहे हैं।
ocular trauma. If you always listen about the mode of injury, it will tell you about the lot regarding the trauma, the metallic body, and the things you can suspect inside the eye. And accordingly, you can request the investigation.
So, shall we move on to another presentation?
Yes, sir.
Just one point, sir. Can I raise?
Yes, sure, Dr. Vivek.
Just one point, since this is a PG forum, you must understand that what are the common mistakes which are happening around when PGs are evaluating. One of the common mistake which I have seen that once they detect few signs or signs are there, they leave behind most of the signs. So like if there is a small hyphema, they are happy with finding out the small hyphema. Now, once a small hyphema is there, one should look for the plethora of signs which can behind those hyphema. So in that scenario, Dr. Salil's presentation was apt. He enumerated most of the findings, and one should remember that all these things can happen even with a subtle of trauma. So as a postgraduate, one has to find out most of the signs rather than be happy with finding one or two signs with a blunt trauma. That's my take.
Okay, nice. Thanks, Dr. Vivati. I should move on to another presentation by Dr. Nandan Kumar, who is a bright student from JNL Jawaharlal
Thank you, sir.
Bhagalpur, and second year PG you are?
Yes, sir. Thank you, sir.
He is going to present on penetrating ocular trauma and its management part. So, Dr. Nandan, please go.
Yes, thank you, sir.
Go with your presentation. Slides up, please.
Yes. Am I audible to everyone?
Yeah, well
Yes.
audible.
Yes. Good evening, respected sir, respected ma'am, my seniors and my dear colleagues. Thanks for giving me opportunity to present a webinar on the perforating ocular injury. I am Dr. Nandan Kumar, second year PG from the Eye Department, Jawaharlal Nehru Medical College, Bhagalpur. As we see the injury, there are two types of injury, whether it is a closed globe injury or open globe injury. Closed globe injury can be due to can lead to contusion, lamellar laceration, superficial foreign body. Open globe injury may be further divided into laceration and rupture. Laceration may be due to penetrating injury, perforating injury, or maybe due to the intraocular foreign body. Penetrating ocular injury, it is a single full thickness wound of eyeball caused by a sharp object like needles, knives, pens, and pencil. It may be also due to trauma by foreign bodies at high speed bullet injuries or iron foreign bodies. Epidemiology, it is a preventable cause of blindness in all age group. It is 3 times more common in men, and it is also more common in the lower socioeconomic status population. 50% of the penetrating ocular injury occurs in the 15 to 34 years age group. It is most commonly it is seen in the home, which is 65.4%. Then it is roadside 13.1%, and in the farm, and on the farm side 11.8%, and 4% in the school, and 5.9% in the working place. Effects of the penetrating injury. Effects are the mechanical effects. Trauma may cause the mechanical effects. It may cause the introduction of the infection. It may cause post-traumatic hydrocyclitis. Post-traumatic hydrocyclitis and sympathetic ophthalmitis. These are all potentially serious complications and should be treated as emergencies. Risk factors are the delays in the primary repair, ruptured lens, and the dirty wounds. So evaluation at early stage is must. Evaluation first, as the patient comes to the emergency rooms, vitals should be assessed at first in all the cases due to the chance of non-ocular injury. Face, scalp, and neck should be evaluated in the early stages. Vitals should be measured in all the cases like pulse, BP, respiratory rate, orientation to time, place, and person. After that, we take the history like age of the patient, time and date of the injury for the medical legal purpose, mechanism like whether it is by the sharp or blunt object, and place whether it is at a work, home, or road traffic accident. Sign and symptoms like pain, redness, decreased vision, treatment and intervention already given at the primary health care or from the referral center. Visual status before and after injury is must in all the cases for the medical legal purposes. External examination, scalp, face, and periorbital areas should be assessed for any injury, ocular adnexa, lid laceration, lid edema, or any obvious foreign body protrudings should be evaluated. Visual acuity should be evaluated. People should be evaluated whether it is round, regular, or reaction to light is present or not. Extraocular motility is seen in all the direction, and gauges subconjunctival hemorrhage is noted. In this diagram, we can see the lower lid laceration. Eyelids and lacrimal injuries should be evaluated with major goal of identifying and protecting possible deep injury to the globe. Lid repair should not proceed until globe rupture is ruled out. So if there is a globe rupture, then we should not go for the lid repair. After that, slit lamp examination is done, and the conjunctiva, wounds of conjunctiva are common. It is by the it may have foreign bodies, hemorrhagic chemosis. Conjunctival laceration is also ruled out. If there is a large laceration, then it is sutured with the absorbable suture 80 or 60 Vicryl. In this diagram, we can see the conjunctival laceration is there. Iris and angle is iris prolapse, a sphincter tear is more common in the penetrating ocular injury. Iridodialysis and iridodonesis is ruled out, and in the lens, movement of the lens, that is a phacodonesis, subluxation or dislocation of the lens, and rupture of the anterior or posterior capsule is evaluated. Corneal injury may be linear or lacerated. In the corneal injury, if it is small, then the margin swells up. If the corneal injury is small, then the margin swells up and become cloudy due to a thus restoring anterior chamber by closure of wound. If a small and limited to center, cornea heals very well unless infected. Treatment is a small recent injury, prolapse iris replaced with intraocular pilocarpine and repaired with prolapse iris replaced with intraocular pilocarpine and repaired with 10-0 nylon. If iris is non-viable, then abscess and edges of wound suture. If large adhesion of iris or its prolapse is almost certain to occur. Scleral wounds more than 3 to 4 mm posterior to limbus are sutured completely after thorough exploration. It is also treated with surrounding cryo applications. Dirty wound by vegetative matter, then pyogenic organism cause rapid necrosis of the entire cornea. So we ask the patient for if there is injury by vegetative matter or not, because it leads to the rapid necrosis of the entire cornea by the pyogenic organism. In case of rapid necrosis, ring of infiltration appears 2 or 3 mm internal to and concentric with cornea scleral margin, so-called ring abscess. If organism is Pseudomonas or aeruginosa, extensive chemosis of conjunctiva with green discharge as seen in the image. Liquefaction of cornea is seen, and panophthalmitis may set in later on. Corneal tear. Corneal tear is a partial or full thickness injury, longer sutures near to visual axis, greater tissue distortion, and more astigmatism. So we should try to give the sutures in the periphery as far as possible. Longer sutures put away from the visual axis. Corner periphery closed with long tight sutures. Corneal center closed with a shorter, more widely spaced, minimally compressive tissue bites. Single and interrupted sutures is given to prevent the astigmatism. Equal depth of suturing on both sides. Anterior chamber should be evaluated, and it is evaluated in all the cases. If it is shallow anterior chamber, then it is only sign of occult globe rupture and associated with worse prognosis. If deeper anterior chamber is there, then it is seen the posterior rupture due to extrusion of vitreous from the posterior segment. Pupils should be examined for shape, size, light reflex. A peaked tear drop, shaped or otherwise irregular pupil may indicate globe rupture. Lens wounds cause any injury may cause the traumatic cataract if wound in capsule, a small entry of aqueous causes localized cloudiness. Opacity in form of feathery lines appear in posterior cortex called as rosette-shaped cataract as seen in this image. Rosette-shaped cataract is there which is due to the trauma. Traumatic iridocyclitis is invariable and severe. Lens swelling keeps the iris in contact with cornea and secondary glaucoma may occur. Posterior segment evaluation is done for the vitreous hemorrhage or there is any retinal detachment, retinal dialysis and tear, posterior vitreous detachment, choroidal rupture, optic nerve trauma or any intraocular foreign body as seen in the image. Retrobulbar hematoma may be there, so we must do CT scan as seen in this image. It is a CT scan image and retrobulbar hematoma is there. Investigation, we will do the X-ray to detect the intraocular foreign body, ultrasound via scan for intraocular injuries, CT brain and orbit and MRI. Treatment pre-hospital care, protect from any pressure or any inadvertent contact with rigid shield during the transport. Impaled foreign bodies should be left undisturbed, and in the emergency room, avoid all pressures to prevent extrusion of intraocular content. Administer analgesics and prophylactic antibiotic within 6 hours to prevent endophthalmitis. Treatment of traumatic cataract, if there is a traumatic cataract and complicated by vitreous loss, then first we will remove the cataract, then perform adequate vitrectomy, suture the globe as primary procedure, and insert the intraocular lens in the suitable cases. There is a complication. It may be due to the infection by gas-forming organisms such as Clostridium welchi. They excite a purulent panophthalmitis with brownish discharge and gas bubbles in the anterior chamber. As seen in this image, there is a brownish discharge and the gas in the anterior chamber. Tetanus is a rare complication leading to localized cephalic type of tetanus. Mechanism effects: foreign body may pass into or through the lens by either the iris or pupil, iris and geniole, or directly through the sclera. If comes to the vitreous, remains suspended for some time, then sinks to bottom, leading to vitreous degeneration. Occasionally, it passes the cords and comes to rest in the orbital tissue known as double perforation of eye. Sympathetic ophthalmitis is a rare complication nowadays, but it is most known complication. This is a condition in which serious inflammation attacks the sound eye after the injury to the other. These factors are wounds involving the ciliary body, suppression in the exciting eye following cataract or glaucoma surgery, ND-YAG cyclophotocoagulation, beam irradiation. Children are particularly susceptible for sympathetic ophthalmitis. Duration: it begins 4 to 8 weeks after the injury of exciting eye. Onset occur as early as 9 days after accident and may be delayed for months or even year. In 80% cases, occur within 3 months. Etiology is autoimmune, T-cell mediated due to uveal pigment act as antigen. Symptoms are decreased near vision. It is the first symptom due to the involvement of the ciliary muscle. Hemorrhages may be there, congestion, lacrimation. Retrolental flare is the first sign seen on the slit lamp. Tippage and Basaka nodules may be seen in this diagram. Tippage nodules are there. It leads to chronic persistent inflammation in injured eye. Though rare, the disease is sight-threatening, so prompt recognition with early and long-term steroid therapy helps to salvage the vision. Treatment: prophylactic systemic antibiotics are indicated in all the cases of globe rupture. Cefazolin arrests bacterial cell wall synthesis and inhibits bacterial replication. Ciprofloxacin provides excellent coverage against staphylococcal organism and Pseudomonas, but not against Streptococcus. Clindamycin cover both streptococcal and anaerobic organisms. So multi-drug therapy is given in the case of sympathetic ophthalmitis. Do not flush the eye with any liquids other than saline or warm water, or even better, do not touch the eye. Do not remove the object out of eye. Do not put any pressure on eye. Do not rub your eye. And what to do? Flush the eyes with copious amount of saline or warm water until symptoms resolve, unless it is severe penetrating or bleeding injury. Advise patient against rubbing or moving the eye, as this can cause further damage. If injury is severe, place a moist pad and loosely bandage the eye. A small penetrating object, use cup to cover the object. Thank you. Thank you, sir.
Thank Dr. Nandan for your extensive talk and very well presented, and you covered most of the things. And one thing I would like to ask that if a patient comes to you, do you advise any investigation like X-ray or something like that too?
Sir, if it is intraocular body, if intraocular foreign body is suspected and ultrasound via scan is not there, then we can go for X-ray in the first attempt.
Sir, please stop this.
Can I ask some question, Dr. Nandan?
Yes, sir. Yes, sir.
Stop screen sharing first, Dr. Nandan. Then
yes, sir.
It was your first presentation.
Sir,
was
yes,
it
sir.
your
Here,
first presentation?
No, sir. Here I also presented in my college, sir.
Okay, okay. It is a very nice presentation and
Thank you,
elaborate also.
Yes,
But few things I would like to just, it is a suggestion.
Yes.
If a patient comes to you with history of injury,
yes,
and he cannot open his eyes, what
Yes,
are you
sir.
going to do?
Sir, and then if it is due to the lead edema, then we will try to open the eye if the globe is intact. If the globe
How do you know that globe is intact when he is not opening the eyes? See, I know
Yes, sir.
you should never try to forcibly open any eye which is closed after injury, because it may be harboring a perforation. And while opening the eyes with forcefully, it means you are going to do expulsive type of thing.
Yes.
So this should be examined under either general
Ultrasound.
anesthesia,
Yes, sir.
and never try to push forcibly open the eyes or put any drop or ointment in any eye with the who has history of injury.
Thank
This
you.
is
Sudhir.
my suggestion.
Sudhir,
Yes,
That-
sir.
I have to ask one question to this young boy.
Yes.
चूंकि ये मेरे मेडिकल कॉलेज का है.
जी sir.
How many injury he has seen it first in his OPD, and what type of OPD injury he has seen? What he said is all theoretical, but has
Yes,
he
sir.
seen any injury case?
Yes, sir. Like injury by a stick, sir. Injury by the
चलो,
fist.
तुमने एक लाइन बोला था बेटा अल्ट्रासाउंड कराएंगे. क्या
Yes,
भागलपुर मेडिकल कॉलेज में अल्ट्रासाउंड हो रहा है आई का?
Now it is not working, sir, but it was working
Okay.
3 to 4 months back, sir.
चलो.
Before one thing, I like to.
But we refer the patient to the private.
Sir, just to Dr. Nandan, such a nice presentation with comprising all the things at your stage, we were unable to do that. But there are few things sir has already pointed out. Few
Humming sound
practical
पीछे
things.
से आ रहा है.
Unless the things are not being done or experienced by the persons in hand, it will be difficult to do that.
Thank you, sir.
In perforating injuries, you have already highlighted all the things.
Yes.
You have to mention some classification system. There are multiple classification system to add on, and that gives you the prognosis as well, and
Yes.
as well as the intervention to act. And this will give you a sort of more scientific way to approach a patient. That's my
Thank you,
suggestion, number one. And definitely it was a very good presentation at your stage. And try to keep all those things in your mind, and always give some time to have the history of the patient.
Thank you, sir.
Thank you, Dr. Ajit. Since Dr. Milind has pointed out the role of ultrasonography, so before referring patient for ultrasonography, you must check the integrity of the globe.
Yes.
Otherwise, you will lose the eye, some content of the eye.
Thanks.
So if it is not perforation, then you can always go ahead for. And if you, as Dr. Sudhir has already pointed out, if your eye is not, don't try forcefully to open it. Take some time. Take some time, 2-3 days before it's open up, or you do under GA if condition situation permits. Any question from anybody, sir, or should you move another?
These perforating injury patients usually roam around 2 to 3 patients, 2 to 3 doctors.
Yes.
Yes, sir.
Always. So if you are lucky that if you are third doctor of that patient, then he can take the treatment from you.
Yes.
If he came for the first time to any doctor, so if any urgent treatment is required, and if you explain the prognosis, he will go to the other doctor.
Yes.
No,
Yeah, exactly. This
but
happens very
definitely
practical tips, Dr.
Kale, Kale has put a very valid point, and this kind of patients, they keep on roaming around. But our duty is to tell them the truth, and at the same time, if we are not ready to take up the case, I will say it's better to refer to the center where it can be done.
So
that is also a right idea.
Dr. Dwivedi, 1 second. Pranab sir, 1 second. Pranab sir, 1 second.
Bolo na.
Nandan.
Yes, sir.
When you have to refer a patient, because he has
Yes.
used the word refer,
Yes.
what precaution and what you will do on paper and with the patient in referring a case to higher center?
Sir, we will start the antibiotics, sir, systemic antibiotics. We will start the systemic antibiotics, and then we will give the topical antibiotics as well, if possible. And then we cover the eye with the bandage, pad and bandage, and then we will refer, sir.
Anything more?
So what is the role of systemic antibiotic in this case?
Sir, it is perforating ocular injury, so there may be chances of introduction of infection.
No, so role of systemic antibiotics, once there is a perforation, the antibiotic which penetrates intraocular, like ciprofloxacin, should be
Yes,
given.
sir. Ciprofloxacin
Already mentioned in the book. Or if you putting the topical drops, if you have a blood level of higher level of antibiotic in your blood, so absorption of the topical antibiotic would be the less into the blood, so it acts locally for the long time. This is the explanation given by in some books and all.
The systemic has to be given added.
Systemic has to be given, yeah, because if patient
also
goes to the
see
court,
the
medical legal problem also in those patient goes to the court, the judge को यही समझ में आता है कि एंटीबायोटिक दिया कि नहीं आपने खाने के लिए.
Has to be covered broad spectrum antibiotic.
Yeah, it has to be.
Sir, with acetazolamide also, if there is any blunt injury.
With acetazolamide
should be to do the needful for the patient.
Yes.
The approach should not be the referral.
One thing I liked in his presentation, Dr. Nandan, he stressed upon the physical overall examination of the patient.
Yes.
Actually, we focused on the eye part, so we missed the most of the things like other head injury type kind of thing, any fracture part and something like that. So he first emergency treatment should be first we have to look for there is emergency for the patient or not. Sometimes patient usually आँख में चोट लगा आँख में चलाया, but they might have some intracranial injury. So I have come across the very few cases of like that.
He has a beautiful collection of the pictures as well.
I can
say.
बहुत unique है.
और एक चीज मेरा experience इतना है कि penetrating injury should be treated at the first sight. I mean, we should not lose much time.
Yes, that is very good. So now we moved on to another
do the
presentation.
patient, not to refer it.
Should we move
At least the primary repair should be done at the first shot.
Okay.
It is very difficult to get a consent from the patient.
The patient
the primary
do agree. Our approach should be to do it.
We have to do our best.
Yeah, I agree with Nilesh. Our approach has to be that proactive, and we have to see that they also agree to it.
These are clinical. These are OPD clinical management part and comes.
Yeah, exactly. And the documentation, as Dr. Nilesh said, that is a must. because we do not know how the eyes are, the patient is going to behave.
Better than the treatment part. Better
But
than
in,
the
med-
treatment
but
part.
in medical
Documentation is
colleges,
very
the
important.
patient, once patient goes to the medical college, they stay there only because
Yeah,
they know that
yeah,
usually
that,
the patient who roam around private practitioner roam to some few people. Or if you explain something like you have honestly explained at first go, he might come after after consulting 2-3 doctors to you for treatment and all. So that is
from medical college you cannot refer it.
सर पहला क्वेश्चन अगर पूछता है सर कि सर मत शंकर नेत्रालय जा सकते हैं,
जाइए,
क्या जवाब देना?
नहीं, उसका यही जवाब हम यही जवाब
देते हैं कि पहले रिपेयर करा लो तब जाना।
मेरे ख्याल से यही
नागेंद्र सर,
हाँ,
गुड इवनिंग सर।
गुड इवनिंग,
गुड इवनिंग मैम।
पम्मी है।
यस डॉक्टर पम्मी, आपका अच्छा आ नहीं रहा है।
हाँ सर, वही माय पीजी इज प्रेजेंटेड।
वेरी नाइस प्रेजेंटेशन डॉक्टर पम्मी।
बहुत अच्छा प्रेजेंट किया है।
Photo here only, and you must have guided him very well, I think so.
Yes sir, but I joined late due to the network problem, sir.
No problem.
Sorry for that.
And his presentation was excellent, very nicely, well covered.
Thank you, sir.
Very nice presentation. Very nice presentation by Dr. Nandan.
We will, sir. Yes, Abhishek, continue.
And Dr. Nandan, your president also belongs to Jawaharlal Nehru Medical College.
Yes.
Thank you, sir. Our honor.
Thank you,
sir. I want to ask one question.
Yeah.
I just want to ask one question from Dr. Nandan.
Yes, sir.
He told that eyelid injury should not be repaired.
Yes, sir.
In getting injury. So
Yes,
I just want to know from you, what should be the sequence if there is injury in the sclera, cornea and limbus, along with eyelid injury, what would be your sequence of repair? Anyway, you will not leave eyelid injury as such.
Yes.
What should be the your sequence?
First we will repair the cornea, then sclera, then eyelid.
First you have to repair the limbus. Then move
Yes,
forward.
Yeah.
So
Yes,
cornea, sclera, then eyelid.
Yes, sir.
So
Yes, sir.
Limbus should be well opposed.
Yes, sir.
So
Yes.
that you can anatomically oppose the position.
Yes. Thank you, sir.
Lid can be taken secondary also. If patient doesn't allow, we can take it after 1 week also, sir.
Yeah.
Thank you, ma'am.
Thanks for all your input from various various audience.
Thank you, Dr. Pammi, for such a
Thanks, Dr.
nice
Pammi, Dr. Nandan. And now move on to another topic. Dr. Pragati Raj from RIO is going to present on ocular adnexal injury and management of it. Dr. Pragati, please go ahead with your presentation.
Am I audible, sir?
Yeah, it is audible and it is visible also, but we have to go on the slide. So, yeah.
Good evening, everyone. Today I'm here to present on the topic ocular adnexal injury and management. Ocular adnexa includes the eyelid, bony orbit, extraocular muscles, lacrimal system, and the optic nerve. As we have discussed earlier, the Birmingham Eye Trauma System classification divides the injury into closed globe and open globe. Closed globe includes the contusion and lamellar laceration, and the open globe includes the rupture and laceration, which further divided into penetrating, perforating, and intraocular foreign body. A patient with orbital adnexal trauma, first of all, we have to maintain the airway, breathing, and circulation. Then we have to rule out the cervical spine injury that is very common in cases of trauma, and perform other neurological examination, and tetanus immunization status should be checked. Pain and orbital swelling may hamper with the proper eye examination. Lid repair should be taken only after the globe has been examined to be intact. In history, the mechanism of injury and object of trauma is very important. We have to know about if there is any history of bite or claw injury that is more prone for canalicular lacerations. Visual acuity should be checked. Diplopia should be seen. Pain on a jaw movement that signifies zygomatico-maxillary complex fracture. History of loss of consciousness. Known allergies and medication should be noted. And most recent food or liquid ingestion should be documented if the patient has to be taken under general anesthesia. So on examination, the first thing is the ocular examination, where we need to note the visual acuity, pupillary response, intraocular pressure, slit lamp examination, and dilated fundoscopy. The periocular examination that includes the extent and depth of laceration. The lid margin should be examined for contour and notching. Lid position and levator function should be seen. The punctum examination should be seen. Lateral displacement of punctum shows some canalicular damage. The canthal angle should be examined for rounding or displacement. The orbital examination includes the extraocular movements, diplopia, hyperesthesia, orbital rim palpation, proptosis, and enophthalmos. Facial head and neck injury should also be examined. So these are the pictures showing lid laceration, enophthalmos, and the medial lower lid laceration involving the canalicular system. General surgical consideration is the most important is to localize the extent and depth of the injury. Decontamination by high flow irrigation should be done by along with removal of any apparent foreign material. Restore the integrity of the wound in 5 basic components, that is the anterior lamella, posterior lamella, canthal tendons, upper and lower canaliculi, and levator complex, the last 3 being the most important. In eyelid laceration, it is said to be simple if there is skin and muscle involvement with little tissue loss. In this, good irrigation and remove the devitalized tissue, and horizontal muscles approximate themselves, but the vertical muscles are sutured by Vicryl H0. Complex lacerations are the stellate lacerations with tissue loss and injury going deeper into the muscle. So in these cases, the devitalized tissue is removed, and then the the edges are freshened up, and then the suture is placed. Care should be taken to not shorten the anterior lamella so as to cause a retraction later. Marginal laceration, the margin of the wound is freshened to create straight and parallel edges, and the tarsal excision is done perpendicular to the wound margin. Traumatic levator dehiscence is if the septum is disrupted and orbital fat is prolapsed, levator complex should be identified and repaired. Detached levator should be sutured to the tarsal plate as its normal attachment level. Canalicular and lacrimal system injury should be repaired as soon as possible. The diagnosis is by direct visualization or probing by Bowman's probe. Stent is placed across the transected portion of seaward canaliculus, and 2 Vicryl sutures are placed at anterior and posterior end of the canaliculi. Lid repair is done using Mercer 6.0, and then the Vicryl sutures are approximated. Stent can be left for 3 to 6 months. Medial end of the seaward canaliculi is identified by fluorescent dye, viscoelastic, or air with normal saline pool in the medial canthal area. The optic nerve injury could be because of direct penetrating injury to the nerve, optic canal fracture, blunt forehead trauma, and the clinical feature include uniocular decrease in vision, afferent pupillary defect, and scotoma with normal fundus and clear media. The prognosis depends upon the visual acuity, history of loss of consciousness, lack of visual recovery after 48 hours, abnormal VEP, and presence of optic canal fracture. Management is high dose IV and methylprednisolone for 48 hours and then the tapering of it. Orbital fracture, the first sign that we see is either exophthalmos if it is a roof fracture and there is herniation of the anterior cranial structures, and the chronic hematic cyst. Enophthalmos is seen in floor fracture and cicatricial changes causing the fibrosis. If the lateral orbital rim is intact, Hertel's or Lute exophthalmometer is used, and if not, then much exophthalmometer can be used, in which uses the eyebrow and cheek as the reference point. So in cases of fracture, globe displacement has to be seen. Then the orbital rim should be palpated to look about apparent fracture site. Intercanthal distance is increased. That is, the telecanthus is seen in cases of soft tissue injury and the mid-facial fractures. And if the ratio of interpupillary distance and intercanthal distance is less than 2:1, then that is significant to show telecanthus. Nasolacrimal drainage system is examined. Infraorbital nerve sensation is checked. Orbital emphysema is seen. Ocular motility is checked. Force duction test is done, and the pupillary response is checked. The investigation, the plane radiograph is used, is ordered. The Waters view, in this it is blowout fracture is very clearly evident. The Calwell-Luck view is done specifically for superior orbital fissure and the frontal sinus, and the lateral projection is done for roof, lateral margin with frontal sphenoid and maxillary sinus. The Rees view is done for the optic foramina, and the cranial base view is for the sinuses and the zygomatic arc and lateral wall. The CT scan is most useful in initial assessment of trauma. Axial scans is done for the medial, lateral, and posterior wall of the orbit, and the coronal scans for the orbital floor and inferior rectus muscle. Pony fractures, soft tissue incarceration, subperiosteal hematoma, intraocular foreign body, and the vascular lesions are well defined in CT scans. Leaford classification, the facial fractures are divided into three types. That is the Leaford type 1, that is the horizontal plane of fracture that separates the teeth from the upper face. Leaford 2 is the pyramidal fracture with extension into the medial wall and the floor of orbit, and Leaford 3 is the craniofacial disjunction. The tripod fracture is the fracture of zygomatic arc on its posterior, inferior, and lateral articulation. But if there is no displacement, no repair is needed. If displaced and depressed, then open reduction and internal fixation or closed reduction is done. Oral surgeon should be involved when mandibular excursion and dental occlusion is affected. Orbital roof fracture can be life-threatening due to direct CNS injury, intracranial foreign body, dural tear causing CSF rhinorrhea, brain abscess, or meningitis. If it is large enough, then repair by primary pericranium or bone graft is done. Medial wall fracture is evident as an emphysema. It is generally self-limiting. Orbital floor fracture can be direct if the inferior orbital rim is fractured, and if it is said to be indirect if the floor is fractured with the rim intact. The direct signs of orbital floor fracture is the globe ptosis and an acute enophthalmos, and indirect signs include orbital emphysema, intraorbital paresthesia, and restricted globe motility. Smaller roof fracture are more prone to cause muscle entrapment. The management, the indication is only if there is diplopia, gross enophthalmos, or hypophthalmos. Timing depends upon the associated injury, degree of impairment, and patient's age and condition. We should wait for the edema and hemorrhage to subside, and steroid can hasten resolution of edema. Surgical approach, subciliary translate inferior orbital rim approach, Calvin-Luck approach, or transconjunctival cul-de-sac approach. Orbital septum should be preserved. Autologous or alloplastic implant can be used. Calvarium is the graft of choice, and alloplastic. If we go for alloplastic implant, then How Medica bone cement is the choice. Contusion is the crushing of subcutaneous muscle and connective tissue with secondary hemorrhage and edema. The management is ice pack for the initial 24 hours and later the hot packs. Initial indication for IND is infected and tense hematoma or the large hematomas. Complication could be infection, abscess, or necrosis of the overlying skin. Abrasion is treated by copious irrigation and cleaning of foreign body and necrotic tissue by prophylactic antibiotic ointment. Partially avulsed or rolled edges could be rolled out and sutured in place. If wound is deeper than dermis, then surgical repair is warranted. Edema is due to intravascular leakage into the soft tissue. Lateral spread prevented by the fascia of eyebrows or malar and nasojugal folds can obscure a penetrating eye injury or restrict the extraocular movements. Oral steroid can hasten the resolution. Hemorrhage is managed conservatively if there is no threat to vision. Immediate intervention is needed if there is optic dysfunction, optic nerve dysfunction, dangerously elevated IOP, and retinal or choroidal ischemia. Blood may remain loculated to form chronic hemattic cyst known as cholesterol granuloma, and it could collect in the subtenal space, intraconal, extraconal, subperiosteal, or the nerve sheath space, and according to that, the type of proptosis is seen. Carotid cavernous fistula can be seen. A high flow fistula is seen generally in trauma, and that is the clinical features include painful ophthalmoplegia, diplopia, periorbital edema, chemosis, proptosis, conjunctival congestion, and elevated IOP. The signs could be orbital pulsation, COX-2 scleral vessels, ocular cranial druid, choroidal thickening, retinal venous congestion, ptosis, and tinnitus. On MRI, there is dilated superior orbital vein. Emphysema is caused by the pressure gradient forces air across a disruption of the PNS and orbital bone and in the orbital tissue. In case of one-way valve effect, optic nerve and retinal ischemia with blindness can occur that leads to orbital compartment syndrome. An emergency decompression is needed in visual loss, Marcus Gunn pupil, or CRO. Ptosis is due to eyelid edema or hemorrhage. Ophthalmoplegia could be because of edema, hemorrhage, emphysema, nerve injury, muscle entrapment, or contusion, and carotid cavernous fistula. So there was a case of 10-year-old male child with complaints of pain in the left eye, sudden loss of vision in the left eye, epistaxis, swollen upper lid, superficial burns on the face, more pronounced in the left side. He had a history of firecracker injury with no history of loss of consciousness. So on local examination, there was a left-sided facial edema, tenderness on the anterior aspect of left maxillary sinus, left-sided epistaxis, lip angioedema, disrupted left eye globe, superficial burn marks on the entire face, and hairs on the anterior scar were burnt and mottled. Right eye examination was within normal limits, except for some superficial burns on both lids and eyebrows. On radiological investigation, there was anterior, lateral, and inferior wall of maxillary sinus was fractured with 13 mm fracture segment in the sinus, undisplaced fracture of the cribriform plate. There was ruptured left eye globe with multiple foreign body seen anterior to the ruptured globe, and displaced fracture of the medial and inferior wall of the orbit. So we had stabilized with the IV fluids. IV antibiotics were started, topical antibiotics and regular cleaning was done. Consequently, after ENT and OMFS clearance, left eye exenteration was done. So this was day two of trauma. This was the day 5 of after post-op, and this was the 1-month follow-up of the child. This is a 13-year-old female with wooden stick injury, came with left eye lower lid laceration and canalicular damage, and the repair was done by putting a stent in the canaliculi. Thank you.
Excellent presentation, Dr. Pragati, and though it is a very vast topic, but you have given very good overview of what to do or what not to do and how to proceed a case of a ocular adnexal injury. And anything from the panelists or any person would like to add? Actually, this topic is almost like it is very difficult to organize in the one presentation, because each and every every injury needs elaborate discussion on that and presentation individually. So with the
I think this
sort
is
of time.
really a very excellent presentation, and she covered a lot. And to keep in mind that this may happen in a orbital trauma or a distal trauma, that is more important. And unless it will be in our mind, we will not go for that. And the results are miraculous. Now the people are taking up for the rehabilitation and other part as well. So you have to be very careful. Even if we are not able to give the vision to the patient, at least give the good cosmesis to the patient, so that he can be on a edge. He will not be less than the other.
One thing.
Very nice presentation. Very nice.
Yes.
Try to cover.
Yeah, one thing I would like to.
Welcome, Dr. Atul.
Dr. Pragati, very nice presentation. Very well said. I understand the topic was very vast. But when you talk about lids, did you forget to mention about the gray line? I mean, we are sort of older surgeons. We always tend to swear by the gray line, you know. When you talk about lid injury, please do mention about gray line, and you have to maintain the anatomical structure of the eyelid. So gray line is important. Please do bear that in mind.
Valiban.
Well,
Hello.
Yeah, Dr. Pami, go ahead.
Yeah, one point I want to add, sir. If in emergency, if a patient comes with a trauma to the ocular structures, first we have to stabilize the patient, that we have to do the ABC, that airway, the breathing and circulation. After that, one thing we have to note is the pupillary reaction, which is very important. If you want to save the vision, if the patient comes to you in the emergency within 6 to 8 hours, and if there is RAPD or Markhansgauer pupil, please start methylprednisolone to save the vision from the traumatic optic neuropathy. The dose I have saved some other eyes if the patient comes in the emergency department in my medical college.
What dose do you use?
Is it to be used in all cases?
No, if RAPD is there, sir.
No, suppose patient come with blunt trauma, vision loss, you could not find any significant finding to corroborate with the visual loss. So you can expect that there might be some trauma. Then in those cases, you can start methylprednisolone. Okay.
What should be the dose of methylprednisolone?
Sir,
1 milligram per kg per day for 3 days, sir.
Actually, it is divided into, as per the ONTT trial, it is 250 milligram every 4 hourly for 3 days. It is total 3 grams in 3 days with 5% dextrose. So fluid overload should also be looked for. So we follow that guideline only. ONTT trial guideline we follow in other. Although you can use mega dose dexamethasone.
ONTT trial is regarding
dexamethasone 200 mg.
Yeah.
200. What is that?
So ONTT trial is not for traumatic optic neuropathy.
No, it is not for the trial is, but we follow that guideline only because it is the safety evaluation of the methylprednisolone in this trial. So you have to use. Yeah.
So many a time in emergency and ICU, the patient is already on a dexamethasone therapy.
Yeah, I know.
Fine.
Yes,
okay.
yes.
If patient is not in ICU,
the decision is
to your clinic, then you can use.
Yes, the decision is to shift from dexamethasone to methylprednisolone, and it must be in consultation with the neuro-ophthalmology or the surgeon there, because general condition also depends upon many things. So
why to shift from dexamethasone to methylprednisolone when you have already added dexa in the adequate dose? Then there is no need of shifting to methylprednisolone.
Dr. Ajit, actually, I have seen many cases who are a normal patient clinically. They have only specifically optic nerve injury.
Yeah.
Yes.
So in all those cases, high dose of steroids for at least 7 to 10 days is recommended. And if it because this will reduce the inflammation and edema. and that is going to save this further optic nerve injury. And this recommendation is basically for to prevent the further injury to optic nerve injury, which is specifically present in blunt, like a ball injury or something like that, in which our road traffic accidents in which there is fracture, injury, concussion to the optic nerve. But the patient is already ambulatory and they are doing well.
Sir, if there is no sign of pupillary sign, if there is no pupillary sign in any cases, we can assume that there is no traumatic optic neuropathy and edema in that. It's many a time it's a situation. So adding to every
agreed with Dr.
Many
optic neuropathy is
also
something
distorts
like optic neuritis here. Everything is all right, but the vision is decreased and pupillary sign is RAPD is there. Then only we assume that there is inflammation to or injury to the or concussion to the optic nerve.
Yes, sir.
Definitely, sir. Definitely, I agree, sir.
So, Dr. Pragati, one question is there. In case of blunt trauma, many times there is traumatic mydriasis. So, how to interpret whether there is RAPD or not?
देखो अदर आई में ना अच्छा क्वेश्चन उनसे है सॉरी
Pragati, answer it. Traumatic mydriasis अगर है, so what else would you like to see?
We can see for the other eye, consensual
light reflex.
Consensual reflex can be checked for it.
नहीं सही बोल रही हो ठीक है इसमें जोर से बोलो
The other after shining the light on the other eye, the consensual reflex could be checked in the affected eye, sir.
Yeah, definitely.
इस पूरे एक्सरसाइज का मतलब है कि पेशेंट जब आए तो आपको सारा पता होना चाहिए कि इसमें क्या क्या चीज हो सकता है. अभी आपको खोजना बाकी है, बस यही मकसद है इसका. बाकी जब आप खोज लेंगे तो कहीं ना कहीं से जवाब तो ढूंढ ही लेंगे और उसका मैनेजमेंट भी ढूंढ लेंगे. इसलिए कोई ऐसा बड़ी बात नहीं. आइडिया है कि उसमें जैसे पहले भी बताया किसी ने कहा फीमा देख करके बाकी छोड़ दिए, कॉर्नियल परफोरेशन देख के बाकी छोड़ दिए, तो वो चीज नहीं होना चाहिए. पेशेंट को अगर नहीं समझ में आ रहा तो एडमिट कर लो, भर्ती कर सकते हैं. आप लोग तो बड़ा हॉस्पिटल में जहाँ की कॉन्फिडेंस लेवल ज्यादा होता है. ओपीडी में जैसे अग्रवाल बता रहे थे केएल की 3-3 डॉक्टर के पास जाता है, तो पता नहीं इसलिए जाता हो कि सब डॉक्टर कहीं भूखे नहीं मर जाए, तो सब और कोई बात नहीं. ठीक
रवीश कुमार टाइप बात करते हैं.
रिलेटिव आरएपीडी का मतलब ही है कि रिलेटिव अपरेंट पिपुलरी डिफेक्ट. अदर आई पीपल अगर डिस्टॉर्टेड है तो डिफिकल्ट टू लिसेट, बट कंसेंसुअल लाइट रिफ्लेक्स वी कैन ऑलवेज सी इन द नॉर्मल आई, assumed normal eye. So thanks again Dr. Pragati, and I move on to another presentation with the permission of the house. Now it is Dr. Farhat from NMCH who is going to present traumatic subluxation, a case report. Dr. Farhat, please share your presentation.
Am I audible, sir? Am I audible, sir?
Yeah, it is audible, and we can well see your presentation also.
Good evening, sir. Myself, Dr. Farhat Parveen, second year PG, MS Ophtha, NMCH. Thanks, boss, to give this opportunity. Today, my topic of presentation is traumatic subluxated lens, a case report. Introduction. Ocular trauma is one of the important causes of ocular morbidity in developing countries. Lens subluxation caused by many reasons, and most common is ocular trauma, followed by ocular surgery and spontaneous subluxation due to hypermature cataract. Ocular trauma and surgery exert an external force on the lens journal Case report. A 75-year-old male presented to IOPD and
I think the net is weak.
Patna with complaint of dimming. He reported a history of trauma to right eye 1 month ago with wood stick. Systemic history was not significant. We can see in this image inferiorly subluxated lens. On examination, his visual acuity was hand movement with PR accurate in right eye and 624 in left eye. IOP was 18 mmHg and 17 mmHg in right eye and left eye respectively. Extraocular movement were full in all gazes in both eye. Confrontation visual field were full to finger count in both eye. On slit lamp examination, cornea were clear in both eye. There was iododonesis in the right eye, and the lens show inferior subluxated cataractous lens with moderate severity as shown in the picture. The lens is uncovered 25 to 50% of dilated pupil, and degree of subluxation is from 9 o'clock to 2 o'clock. Rest anterior segment is within normal limit. Left eye shows IMSC and rest anterior segment was within normal limit. Fundus examination were unremarkable in both eye. Vitreous was clear in both eye. CD ratio was 0.4:1 in right eye and left eye respectively. Disc flat, distinct margin and no excavation or notching noted on optic nerve in both eye. Management. We have two management plans. Plan 1 is manual in small incision cataract surgery with CTR capsular tension ring implantation with IOL implantation. Plan 2 is manual small incision cataract surgery with scleral fixating IOL. In this patient, we managed by Plan 1. A 6 mm sclerocorneal tunnel was made. Capsular axis was done. After capsular bag stabilization by capsular tension ring, a 6 mm PMMA IOL implantation was done into capsular bag and haptic were aligned in subluxation meridian. If capsular bag stability is not found, then we will go for scleral fixation IOL. This is the image of first post-op day. Patient had clear cornea with well-centered IOL. His uncorrected visual acuity was 6/36 in right eye and 6/24 in left eye. After 1 month, best corrected visual acuity is 6/6 in right eye and 6/9 in left eye. Discussion. Patient diagnosed with subluxated lens secondary to blunt ocular trauma. No, patient had no family history of Marfan syndrome, pseudoexfoliation syndrome, homocystinuria, or Weil-Marchesani syndrome, as all of these genetic conditions are mostly bilateral subluxation rather than unilateral subluxation. A sudden reduction in vision following trauma may suggest commotio retina or retinal detachment. Commotio retina or Berlin edema could have occurred at the time of injury. This case was managed by manual small incision cataract surgery with CTR implantation with PMMA IOL. The reason for PMMA IOL implantation was they are rigid, less bulky, and more stable than foldable IOL. Haptic of these IOL also stretch capsular bag gives extra support to subluxated capsular bag. However, patient was correctable to 6/6 right eye following refraction, and fundus findings were unremarkable post-operatively. Conclusion. Blunt ocular trauma can cause a multitude of ocular complications like ecchymosis, hyphema, subconjunctival hemorrhage, cataract, extraocular muscle entrapment, angle recession, iridodialysis, cyclodialysis, lens subluxation, and retinal detachment or break. A full comprehensive eye examination is necessary to rule out these complications. Genetic causes should also be ruled out, especially if subluxation is bilateral. Treatment for this complication can be complex, however, prognosis can still be excellent following ocular trauma. Thank you.
Very good presentation, Dr. Farhat. I think you have covered well, and I always wonder the amount of trauma leading to subluxation. We could not find any retinal problem or other problem. So in my mind, there happens to be some weakness of the granule that might aggravate after the trauma. So it is very surprising to find that isolated. I have seen many cases, traumatic subluxation, post-trauma subluxation and all. So
Okay, Dr.
we
Farhat,
could, how many clock hours was there in
Yeah. What is the
subluxation?
degree of
Dialysis
subluxation?
degree?
Degree of subluxation is 5 clock hours from 9 o'clock to 2 o'clock.
9 to 2 o'clock. Okay. And Dr. Nilesh would like to add something?
Yeah, I was asking that you said that MICS was the procedure and this thing was done. So what would have been the choice given a PECO or a MICS, SICS? That would be preferred because more handling is there in SICS definitely more than a PECO. Secondly, up to what clock hour do you go for a CTR or a segmental ring implantation? And when do you go in for a SFI? These are important things to know when you're dealing with subluxation.
Right.
Phacoemulsification can be done, but this case was managed by SICS. And
Okay, fine, but just to know that because in SICS, the handling is definitely more than if the clock, if you have decided that this will be CTR, the case will be, in the case you will use CTR, okay?
Yes, sir.
Then you want a minimum handling of those zones.
Yes, sir.
So SICS is a little bit more traumatic than a PHECO.
Yes.
Number one. And number two, if the extent of subluxation is more than 180 degrees, then it depends upon the surgeon's skill, whether he wants to go in for a CTR and a segmental ring, or he goes in for a SFI. This always remains a matter of debate. I want the comment of panelists on this issue. The panelists.
I think I also agree with Nilesh, because given the choice between phacoemulsification and subluxated lens and SICS, I would definitely prefer phacoemulsification because that is a more controlled closed chamber manipulation of the lens, whereas SICS is more open and is liable to lead to more subluxation. So a safer choice.
Sir, one.
Yeah.
Regarding the phacoemulsification, I can say just if you don't have just for the beginners who doesn't know the direct chop methods, it is devastating for them to just have it. So in that case, basically,
I mean the first line, the first line I said, given the choice.
Yeah.
Yeah. So if these choice, yeah.
Okay. Actually, you can.
What we are discussing, basically, what we are discussing is not that what we did in this case. It was very nicely done. It was very well done. But what is the best procedure given an option? This also must be known, because it could be SICS could be very atraumatic in your hand. Yes. But in general, it is a more traumatic procedure in subluxated cases where you are very liable to increase the subluxation very easily during any of the maneuvers. So that's why the controlled phacoemulsification is definitely the procedure of choice. But yes, this case was handled. In the beginners, you have to be even more careful. What I said right now, it can be done, but you must.
Nilesh, beginners के लिए ये तो contraindication ही होना चाहिए. If
Rather,
you think that you are a beginner and you are not if you think that you are a beginner, you should not attempt
handle it.
Yeah, refer it to more experienced person.
Yeah, subluxated is not for beginners.
Definitely, sir. This is also, we can take it in other way, just to come up that in given scenario, if somebody does not have a phaco machine, and if they want to do these cases, so it was a very right way to plan in a two-step and take the consent from the patient, and accordingly they did well. The result was very good. So we can accept in that manner. But definitely, phaco with a capsulorhexis segment, CTS and CTR, as well as capsule care devices, would have been a very good choice.
We are not being critical about the way the things have been managed, but we are being critical about the scientific explanation, what we should know.
Yeah.
Because when you are doing this kind of a case, you must bear in mind that you are liable to increase the subluxation when you are doing a SICS, and you may land up in ICC.
Yeah.
But Dr. Nilesh's point is to say that if you are getting subluxed cataract like this, you must refer to, if you are not competent, then you refer to some higher center or some other surgeon. That's why, that is what you want to say. And that is what I want to say.
Safer. If that procedure is better for the patient.
Yeah, definitely. FOCO would be definitely better in my mind.
And
depending upon, of course, who is the operating surgeon.
And with a vitrectomy backup.
Yeah.
Yeah, with a retina.
And the comfort and ease of the operating surgeon as well, with the FACO as well as the SICS procedure.
Yeah.
Nice.
So what we are discussing here is a nicely managed case and in accordance with what would be the best. This is what we are discussing, and we ought to know everything.
Fully agree with you, Dr. Nilesh.
And Dr. Farhad, one more question. At what stage you put in the CTR?
Yes.
Whether you put in the CTR before you take out the nucleus and the cortex, or you do it at what stage of the surgery you prefer to do it?
After hydrodissection. After capsular axis hydrodissection, we can put CTR after capsular axis, after hydrodissection, or after nucleus prolapse, but better it to put after hydrodissection.
I think I also
done in this case.
Yes.
Sir, actually, CTR should be done when you think that now the capsule or bag will be unstable. That is doing maximum of the surgery which can be permitted in that given situation. Because once you put CTR, many steps might become difficult. One. Number two, there may be difficulty in pushing the CTR in a well distended bag, in which there is a lot of lens matter and nucleus. So until you have there is an instability of the bag, one should not put the CTR. This is my take. This is my take.
So majority surgeons insert prior to lens implant, sir.
Exactly. After finishing the, when you think that there,
yeah.
Now
Dr.
this is the bag is not very stable while doing IA, etc. Then that should be put just before the lens implantation.
There is a common dictum, sir, ki CTR should be implanted as late as possible till the bag is stable. Number one. And initially, you can take help from the capsule care devices to complete the procedure. And otherwise, it is very difficult to remove the cortex once you have put the CTR in another plane. But there are, yes.
Yeah, please carry on.
Yes, sir. And definitely the 5 clock hours is a big, I will say 180 degree, more than 180 degree of general dialysis is a contraindication for CTR. You can add with us with the CTS and other devices. With the help of, you can put a CTR with the CTS, but there are multiple suggestions. But best way to do is with the FACO. Use the capsule care in the beginning, and once you have removed the nucleus and as far as the capsule you have removed, put the CTR and put the IO.
Sir. Because once there is a dislocation, the CTR might also get dislocated in the posterior chamber. So handle this dialysis with the hook and then put the ring after finishing the FACO.
Sir, regarding the FACO, just we have a different view, but in SICS, basically CTR we should put after delivery of the nucleus. Prolapsing of the nucleus and nucleus delivery, then do the IA, and thereafter we have to put the CTR. So in SICS, if you want to put the CTR, only one option is there, just after removing the whole content of the nucleus as well as the EP nucleus also. In that case, here in this case, it is better to just have the CTR just finishing all the tasks, just to stability for the lenses, not for the just to support. You need to support. If you don't have just a big axis, then it is very devastating in cases of the SICS. FACO, you have a two choice. Either you put beforehand just nucleotomy and all this thing. After nucleotomy, you can just. But in SICS, always you have to put the CTR just after delivery of the nucleus.
Absolutely, I agree.
After delivery of the nucleus,
point well taken, Dr. Mani.
cortical aspiration also.
Yeah. Also, I said that.
That is what
just before putting the IUL, just you have to yes.
But in phacoemulsification, you can put it at any stage.
Before
at any stage. After hydrodissection.
Hydrodissection.
Prefer to put it at the last.
Yes.
So now time to move on to another presentation. And it is Dr. Ali from Ali Kashar from DMCH, and he is going to present on long-term sequelae of blunt ocular trauma. You might be quite well aware that there has to be some long-term sequelae after the blunt trauma. So what are those? So we are going to listen from Dr. Ali Kashar from DMCH.
Thank you, Nagendra.
Please share your presentation. Thanks.
A very good evening to respected chairperson, panelists, and learned audience over here. Thank you, Dr. Nagendra sir, Chairman ARC, for providing me this opportunity to present. My topic of presentation is long-term sequelae of blunt trauma eye. Blunt trauma, in definition, refers to direct blow to the eye caused by the impact of an object. Patient with blunt trauma should be under close observation for early diagnosis of late complications such as cataract, glaucoma, and proliferative vitreoretinopathy. Coming to anterior segment sequelae, there could be ptosis that could be either mechanical due to the lid, heaviness of the lid, that is due to extensive scarring of the lid, and it could be other paralytic due to LPS paralysis, which in turn is supplied by the third cranial nerve. Coming to eyelid anterior lamellar shortening, in case of vertical wound of the eyelid laceration that heals by fibrosis, leads to the shortening eyelid anterior lamellar shortening. Coming to conjunctiva and cornea, most lesions such as subconjunctival hemorrhages and conjunctival edema or corneal epithelial abrasions resolves without leaving any sequelae. In case of long-standing corneal edema, that may be due to endothelial disturbances or breaks in the Descemet's membrane, may leave permanent scars, which may be associated with neovascularization later on. Coming to blood staining of the cornea, it is due to red blood cells infiltrating the corneal stroma, secondary to hyphema or persistent IOP for persistent high IOP for more than 48 hours. The blood staining slowly clears from the periphery to center, and the whole process could even take for more than 2 years. In cases of sclera, the cases of globe rupture is found to be 3.5% of severe blunt trauma. In globe rupture, there is severe periocular or intraocular hemorrhages could be there. The low IOP less than 5 mmHg is determining. Because of low IOP, there is deep anterior chamber, and for posterior rupture, the visual prognosis is very poor. Iris, pupil, and ciliary body. Iris, because of its mobility, lack of support, and thinness, it's more prone to damage by blunt ocular injury. Lesion of iris is characteristically failed to heal and remains a hallmark of previous ocular trauma. The pupillary margin of the iris appears to be the most susceptible region to trauma, and small iris notches are observed in most patients. There is post-traumatic patchy atrophy of iris trauma, and there could be pigmentary changes, that is pigment clumps on the interior iris surface. Pupil. There could be permanent traumatic mydriasis and pupil being unreactive to direct and consensual light stimulation. Ciliary body, angular-assistant glaucoma caused by ciliary body dialysis. Anterior chamber. Hyphema, that is hemorrhage because of bleeding from ciliary body vessels or due to iris lacerations. Complication could be rebleeding, secondary glaucoma, and corneal blood staining. The risk of glaucoma is reported to be 19% in case of blunt ocular trauma. Blunt trauma could be contusion and lamellar laceration. In case of delay onset glaucoma caused by contusion injury, either an open angle glaucoma or an angle closure. Open angle could be angle recession glaucoma, lens particle glaucoma, phacoanaphylactic glaucoma, hemolytic, hemosiderotic, and steroid-induced glaucoma. Angle closure glaucoma includes lens subluxation or dislocation and phacomorphic glaucoma. The delay onset glaucoma of lamellar laceration may be either open or angle closure type. Open angle glaucoma includes lens particle glaucoma, ghost cell glaucoma, epithelial ingrowth glaucoma, inflammatory steroid-induced glaucoma, and glaucoma associated with intraorbital foreign bodies. Coming to angle closure glaucoma, it could be due to peripheral anterior synechia or posterior synechia, pupillary block secondary to inflammation or flat anterior chamber, phacomorphic glaucoma. Coming to lens, traumatic cataract due to anterior and posterior subcapsular opacity or opaque cortical suture with characteristic rosette-shaped cataract, that is late onset rosette-shaped cataract in case of traumatic cataract. Osseous ring, iris pigment epithelium impression on the anterior lens capsule. Coming to posterior segment sequelae. In case vitreous, there could be synchisis scintillans, that is cholesterolosis bulbi. This follows vitreous hemorrhages, common in men in 5th decades and is a unilateral condition. Choroidal rupture healing sequelae. Tear in the inelastic Brooks membrane, the choriocapillaries, and the retinal pigment epithelium. Neurosensory retina, outer choroid, and sclera are intact. Healing occurs because of fibrovascular proliferation, fibrous scar formation, retinal pigment epithelial hyperplasia, choroidal neovascular membrane formation. Coming to retina. Central vision loss may occur following commotio retini, Berlin's edema, which may be permanent due to retinal pigment epithelium changes and migration, and macular hole formation. Macular hole may follow blunt trauma due to following mechanism: contusion, necrosis, subfoveal hemorrhage, and vitreous traction. Proliferative vitreoretinopathy. Proliferative vitreoretinopathy is one possible late complication after blunt trauma. Poor visual outcome is expected during vitreoretinal surface traction created by proliferative membrane. PVR is observed in more than 70% patients with open globe injuries involving posterior segment and usually progresses to tractional retinal detachment. These are some pictures of anterior segment complication of blunt trauma. Hyphema, sphincter tear, iridodylisis, Voss's ring, cataract, lens subluxation, angle dissection, and globe rupture. The posterior segment complication of blunt trauma, commotio retini, choroidal rupture and hemorrhage, avulsion of vitreous base and retinal dialysis, equatorial tears, macular hole, and optic neuropathy. Thank you.
Thank you, Dr. Ali.
Thank you, sir.
Are you going to present another presentation or?
No, sir. I prepared just one.
Okay, only one. Okay. Thanks, Dr. Ali, for your elaborate presentation. One thing, any panelist could like to add anything?
What is the duration of a ptosis surgery after a case of a traumatic ptosis? When would you like to consider the patient for a surgery?
Pardon, sir. What?
When would you like to go in for a ptosis correction in cases of a traumatic ptosis which has been there?
Ptosis correction.
You got my point. When
yes,
you would
sir.
go
Yeah.
for a surgical correction.
Yes, sir. But
at least 3 months.
Please stop screen sharing, Dr. Ali. Then you can have
screen sharing. Sorry.
Anything would like to answer, Dr. Nilesh question?
So this is, we would like to know, the patient had a traumatic ptosis.
Yes,
there.
Yes,
you want to wait for the things to subside, and then when you want to take it up for surgery, would you take it in the first month, second month, or would you like to wait for certain period of time? That is what is the consensus period, I would say, to wait to take up for the surgery?
At least 6 months, sir.
Yeah.
Less than 6 months.
6 months.
Less than
6 months. Okay.
At least 6 months for spontaneous resolution or
the reasons being that there are multiple traumatic cases, the resolution can happen, or whatever fibrotic changes or things are happening, then you would take up for surgery to decide your procedure, what you have to do to get the predictable results. Otherwise, you may go in for the surgery early and you may have the difficulties and an unpredictable results in that. Number 2, what you said was in a subluxated lens, case report was also discussed, there are many cases in which you don't have a full dilated view of the pupil. Huh? So
Yes,
in
sir.
trauma, one thing what I want to point out is that while taking up a case for a traumatic cataract for surgery, where the pupil has not fully dilated and you haven't been able to fully checked out the zonules, you have to be a little bit prepared that there could be a subtle subluxation on the table, which is discovered on the table when you're doing a rexis and the wobbles.
Yes.
Because in the figure, what you showed as subluxated lens, the pupil was not dilated in your last slide. And usually that happens in traumatic cases. So this is one important point in cases of, because these cases you will operate later on. There is some subtle subluxation, 2 clock hours. Then a cataract develops in due course of time. Patient is corrected with refractive error for quite a long time. That subluxation is causing significant astigmatism, but you carry on. And when he comes up for surgery, the pupil doesn't dilate fully. So you're not pretty sure that yes, subluxation hai ya nahi hai.
Yeah.
In a frank case, you are very clear. So this is one important point which you need to keep.
Sir, asymmetry of anterior chamber depth is.
Those are frank cases, Asif. I'm talking of those subtle cases where you need to be prepared in post-trauma.
Exactly.
Post-trauma.
But asymmetry of anterior chamber depth is very good.
Indicator.
Very frank.
And up to, if in case of trauma,
As
how?
far as the long-term complications are concerned, I think rehabilitation, there is a very common psychopathy, and even the back to the work in those patients who have a loss of globe and loss of the facial configurations. This is also very important structure. So we can assure them with the customized ocular prosthesis and other things, and we can say them that this can be a hope to their near future. Also, we can be a guide to selection of certain professional careers, because a person who has not a good vision, they cannot go for the railways and other things. I think this should be highlighted, and we can tell them beforehand so that they can go for the certain, they will not waste their time in those segments. I think it should be added.
Yes, sir.
Dr. Asif, regarding subtle subluxation,
yes, sir.
2 things one should look for. One is there any asymmetry in the pupil? That is anisocoria. That suggests of any blunt trauma. And you should actively ask for any injury, blunt injury during the childhood or known history of his remembrance. Is there any history of any blunt injury? And these must be these patients must be counseled about that that he may be harboring some dislocation or subluxation, and there is high chance of complication during the surgery. And once I have seen that there was no such thing, but when I put air in the chamber before putting this blue ring, the air was shifted to some other side. That is, on sitting posture, there was nothing, no iridodonosis, no phacodonosis, and everything was normal. But while sleeping, some vitreous was coming into the anterior chamber. So, but most of the time, if there is an anisocoria, one should ask for blunt injury.
Okay.
We are discussing these gray zones. Very important.
Yeah, one more question that comes to the mind: whether all subluxations require a surgical procedure, or can they move on just like that?
Subluxation with cataract requires the procedure. If it is
just a subluxation, not a cataract.
Just a subluxation, if too much of astigmatism is not there, which is disturbing.
There is a clear-cut guidelines. There is clear-cut guidelines. If a phakic zone is more than a phakic zone, we can wait. And if it is more than a phakic, yes.
Yeah. So that is what I was trying to stress, that all subluxations do not require to be surgically treated. We can conservatively treat them depending on the grade of subluxation. And one more thing that comes to the mind is the angle recession concept. the angle recession with a blunt trauma or a penetrating trauma, that can happen even after 1 year to 50 years. So that always has to be kept in mind, that glaucoma may set in such cases even later on. So they have to be followed up for a pretty long period of time.
Very valid point, Dr. Pranav Ranjan. I would like to stress upon the follow-up of those cases, as you rightly said, to look for the glaucoma and later on atrophic hole development and retinal detachment, or some dialysis or retinal detachment might occur. Even might, if there is a choroidal rupture or Brook movement rupture, some neovascularization would be there. So you have to at least keep up your follow-up to the patient up to at least 1.5 years. So you could possibly manage as early.
मेरा वो कहने का मतलब है डॉक्टर नागेंद्र कि अगर 10 पेशेंट किसी को ब्लंट ट्रॉमा का मिल गया तो भर जिंदगी का हो गया खाने का इंतजाम।
जैसे डायबिटीज और ग्लूकोमा के साथ है,
ट्रॉमा केसेस को रेफर मत करिए।
और जहां तक सर्जरी का बात था, मेरा ये मानना था सर कि हर पेशेंट का अपना अपना रिक्वायर्ड विजन है। अगर उसके लाइवलीहुड में प्रॉब्लम हो रहा है तो सर्जरी को बहुत ऑब्जेक्टिवली ना देख करके सब्जेक्टिवली भी देखा जाना चाहिए कि अगर पेशेंट को प्रॉब्लम हो रहा है तो उसको करके अगर कर सकते हैं ठीक तो कर देना है, न कि कोई एक फर्मा में फिट करने की कोशिश
नहीं। वो तो ग्लूकोमा के साथ भी यही है कि अगर वो गरीब कहीं दूर से आ रहा है, वो अपना दवा नहीं डाल सकता है, ही इज नॉट इकोनॉमिकली वेल ऑफ, तो उसको ट्रैप क्यों नहीं कर दीजिए? I mean,
sir, but definitely, sir, there is a constant need and common voice should be towards a traumatic patient that you need. And once a traumatic eye there are so many diseases can happen over a period. And just highlighting one example of rehabilitation part, because one shuttler, the badminton injury player, she got a accidental injury with a rubber seat, and she has to change the profession from the sports, and she was advised to go to the administrative side and management side, and she did well because she was well prepared before. So that should be given an importance while doing the counseling apart from the.
Should I move on to another presentation? This is last presentation. Okay. I request Dr. Shreya to share her screen, and he is going to speak upon the very important medical legal aspect of the trauma. We must know what are the implications of medical legally. Dr. Shreya, please go ahead with your presentation. Yeah.
Good evening, everyone. I'll be presenting on the medical legal aspects in ocular trauma. A medical legal case has been defined as an inflicted injury or disease process where the treating doctor establishes the diagnosis by a thorough history, clinical examination and investigations, and determines responsibility according to the law of the land. List of medical legal cases: all cases of injuries and burns, all vehicular, factory or other unnatural accident, cases of unconsciousness where the cause is not clear, suspected or evident poisoning or intoxication, cases brought dead with improper history creating suspicion of an offense, cases of suspected self-infliction of injuries or attempted suicide. Medical legal cases comes to an ophthalmologist when an expert opinion is required, or as a treating doctor to a medical legal case, or a legal proceeding is against the doctor. As an expert, when an ophthalmic mishap occurs in the treatment or a surgery anywhere in free camps or anywhere in the country, it is inquired by the government or court. A committee of expert ophthalmic doctor is appointed, and as an investigating officer, he has to report or depose on oath in the court of law. When an ophthalmologist has treated or examined a case, he has to give opinion as a second expert in trauma or assault, or give a certificate for compensation purpose, or employee compensation, or for insurance and reimbursement. An ophthalmologist's role is to confirm the etiology, assess the depth of injury, grade the type of injury, and establish the severity of the disability. Injuries are of two types, simple injury and grievous injury. Simple injury is one which heals rapidly without leaving permanent deformity. And grievous injury are of 8 types. And we have to deal with the second, which is permanent privation of sight of either eye. Medical certificate of injury is given to a patient on demand if injury is simple. Grievous injury is a punishable offense under section 320 of IPC and must be reported to the police. Permanent privation of sight. Privation means loss of basic thing that people need for living. Victim must be permanently deprived of one or both eyesight. Temporary privation does not mean grievous injury. Permanent loss of eyesight does not mean that it should be incurable. Example, an injury that causes corneal opacity is a grievous offense, even though it is a treatable condition. A doctor should give advice only when complete healing has occurred, which may take from 6 weeks to 6 months. Only then it can be decided whether a disability is temporary or permanent. When we encounter a medical legal case, either in an emergency or in OPD, then first we should stabilize the patient, and then a medical legal case number should be allotted and documentation should be done, and immediately police need to be informed. Protocol for filing a medical legal report is as under. Police information should be sent in a proper form. Consent of the patient should be taken. 2 identification marks is to be noted. Time and date should be noted. Proper history in patient's own or guardian's own words is documented, and details of police constable who brought the case should be noted. Examination of the injury is done in detail, and diagram should be drawn whenever necessary. Opinion should be crisp and to the point. Avoid abbreviation. Article should be preserved and enumerated. Prepare 3 copies of the document. 1 copy is kept at the emergency room. Other is as a hospital record, which should be kept confidential, and original is given to the police. General guidelines. If a medical legal case is recorded somewhere else and is referred, it should be treated as MLC, but no new MLC number should be issued. If a case is brought several days after the incident, it should be reported and findings to be noted regarding the patient condition to the patient's present condition. And faculty members should sign along with junior resident or the senior resident. Consent for emergency surgery when no attendant is available can be given by the medical superintendent of the hospital. If emergency medical officer in emergency does not register a case as MLC, but the treating doctor thinks that the case is a MLC, then it should be recorded as MLC and should be considered at any point of time, even if it is missed initially. In specific cases, if a patient requires evisceration, then a second opinion must be taken from an ophthalmologist and it should be mentioned. For firearm injuries, bullets, lead shots recovered from the wound or body in a firearm injury should be air dried and then put in a bottle, padded with cotton, documented, sealed, and handed over to the police. Mention about the entry and exit wound. Take extra. Hello?
Yeah, carry on.
Take X-ray of the track or whole body. Never pick the bullet using a metal or tooth forceps. Storage of records. Medical Council of India requires a record to be preserved for a period of 3 years for operative cases, 2 years for OPD records in cases of adult, and for 21 years in cases of children. Medical legal case can be encountered by an ophthalmologist when a legal proceeding is done against him. It can be criminal or civil. It is criminal when there is a criminal negligence or disfiguration of face or treatment has caused death of the patient, and it can be civil due to professional misconduct or civil negligence. Professional misconduct. It is the conduct of a medical practitioner during the practice of his profession, which could be regarded as disgraceful, dishonorable, or disrespectful. State Medical Council maintains the disciplinary control. If a doctor is found guilty, then a warning notice can be issued or erasure of name from the medical register can be done, which can be temporary or permanent. Some examples of professional misconduct are unnecessary advertisement, refusing treatment on religious ground, fee sharing, issuing false certificate, appointing unqualified staff, or treating a patient in a drunken state. Professional negligence or malpractice. It is the lack of reasonable skill or knowledge or willful negligence that led to some damage to the patient. It can be an act of omission or commission. Civil negligence is simple absence of care or of skill. There is no violation of law, and consent of the patient and contributory negligence are good defenses for the doctor. Criminal negligence is gross carelessness on doctor's part, can be tried in court, and Section 304A IPC deals with criminal negligence and punishment is imprisonment up to 2 years or fine or both. Documentation is the most important part. Proper documentation should be made a habit. A meticulous examination along with important negative signs should be noted. Visual acuity, intraocular pressure, pupillary reaction must be noted. Evidence of malingering and signs which differentiate pre-existing illness from the recent injury should be documented appropriately. Follow-up visits, side effects, and warning signs must be mentioned and explained to the patient. Type records are preferred as illegible handwriting can have deciphering issues in cases of legal claims or peer review. Lastly, visual prognosis must be mentioned. Some litigations against ophthalmologists. 942 cases of medical negligence was reported to NCDRC, out of which 30 cases were related to ophthalmology between the years 2002 to 2018. Compensation for cases ranged between rupees 2 lakhs to rupees 1 crore. Most litigation against ophthalmologists are of post-op cases of cataract and cornea. Some examples are in a case of vitreous hemorrhage. Vitreous hemorrhage occurred after Avastin injection and caused temporary blindness. Compensation up to 1 lakh rupees was given. And the reason the court cited was negligence and deficiency in service on doctor's part. Another, in a case of pterygium surgery, the doctor had advised mitomycin C drops, but he did not write the duration. Show the patient continued the treatment that led to damage of his eyes. Contributory negligence by the patient was held by the court. Also, a coolie post-cataract surgery did not take rest, and so he developed corneal ulcer while working in the fields. Court held that he should have been instructed about the post-op care precautions and follow-up. And so how do we protect ourselves as a doctor? First is proper documentation and have a checklist. Second is giving realistic expectations and ensure open, honest communication. Wherever possible, have an electronic backup. Avoid criticizing other doctors. A casual bad remark can affect patients' confidence. Adopt remedial methods for unhappy patients. Res indicate is a suit of damage should be filed within 2 years of occurrence, and contributory negligence is simultaneous negligence on doctors and patients' part. Also, before surgery, take physical fitness from MD physician. Always have a qualified standby anesthetist. OT should have oxygen cylinder, and a written informed consent in patient language should be taken. There is a recent guidelines issued by the Supreme Court for prosecution of doctors. This is to protect doctors from frivolous or unjust prosecution against medical negligence. Supreme Court has held that preliminary inquiry should be made time-bound. The investigating agency should refer the complaint to District Medical Board. The District Medical Board will examine all the allegations within 2 weeks and forward its recommendation to investigating agency. In case of dissatisfaction by IA or doctors, refer to State Medical Board in 2 weeks. State Medical Board would examine the matter in 2 weeks and shall provide reason for endorsing or rejecting the recommendation of DMB. The IA on receipt of recommendations of district medical board or state medical board may further proceed as per law. We must know some things. How much to charge on fee for medical service is the choice of the medical practitioner. Fee paid for operation also includes post-op care. Doctors will be held responsible for the act of commission or omission of their assistants and non-technical staff. Doctor is not negligent if a patient gets a heart attack while doing a minor operation. If a drug is prescribed in appropriate dose for appropriate condition and the patient develops a reaction to the drug, the doctor is not responsible. But if the reaction is not identified and managed in time, it may amount to negligence. The patient does not follow the instruction, then doctor is not negligent. Finally, we continue to live in a fantasy world where we trust the dictum that if we work ethically, honestly, and compassionately, no harm will come to us. Unfortunately, harm has already come, as is seen from multiple court judgments penalizing ophthalmologists. Our association and leaders need to recognize the growing danger and need to take steps to defend the members in their hour of need. Time has now come to introspect and to factor the cost of litigation and compensations into the cost of surgeries so that we not only benefit the patient, but also safeguard the ophthalmologist. Thank you.
Very good presentation, Dr. Shreya. We came to know various litigant part of this in this medical legal profession, medical legal cases. And you have cited very pertinent case study for opening our eyes. So you must always write down the duration and come for the follow-up. So these are the important part for while seeing the patient and if you are treating the patient. So excellent presentation, and we came to know various new things with this presentation, though in this presentation. Thanks. Anybody? Dr. Pranav Ranjan, sir?
Very nice. Exactly what you said. Even I came to know a lot of things, especially for the children. You have to keep the record for 21 years. I never imagined 21 years is a very, very long time. How to keep the record unless you keep it electronically. So that is one part which is an eye opener.
हाथ पर गोदना गोदवा दीजिएगा
So
very nice.
बहुत अच्छा presentation. Dr. Naveen कुछ बोलना चाह रहे हैं?
Yes, sir. Many congratulations, Dr. Shreya had worked hard, very sir. And regarding the visual acuity, I just want to stress that in our college also there is a lot of mistakes while taking the visual acuity. Most of the patients comes to your just a fall play. So we must check the malingering also. We never try to write down no PL immediately. We should either write down patient denies PL rather than no PL just immediately, because if you put the no PL, so there may be chances that you are supporting the grievous injury. So sometimes most of the patient comes to your just government hospital, they just have a vested interest of that medical legal part. In that case, if you write down the no PL, there may be chances that your report is going to be and other doctor said that he had a vision. In that case, there may be chances something irregularity will happen. And regarding the corneal perforation, I have also some suggestion that most of the PG student, what they put the topical medicine also at the time of perforation also. So before repairing, it should not be put in the topical medicine. Try to avoid as much as topical medications in case of ocular trauma, rather than just putting only topical, a lot of topical medication getting advised by that in case of corneal perforation also, and all the different type of perforation also.
So the take-home message of today's
बोलिए नीलेश.
Take-home message of today's seminar: evaluation, documentation, be ready for the medico-legal part of these post-traumatic cases at any point of life, and a long follow-up. This is very important. I mean, proper examination, that every importance has been given. Proper documentation that requires, because of the medico-legal aspect of trauma cases, management will follow as per the examination, and a long-term follow-up. I think these are the important things which have come up with the seminar. Anything or any other panelist would like to add upon anything on this? Take home message.
Nagendra. Dr. Nagendra.
हाँ बोलिए.
First of all, let me congratulate Sudhir boss, ARC, and boss for choosing this topic for today's webinar. Sudhir boss, मैं जो कहूंगा सच कहूंगा, सच के सिवा कुछ नहीं. I feel that ocular trauma is one topic that has been slightly ignored by almost all of us. Many of us are not even prepared to handle these cases in our clinic. And when such a case arrives to us, we simply refer them. PMCH चले जाइए, IGMS चले जाइए, AIMS चले जाइए. Reason being, perhaps visual prognosis अच्छा नहीं होगा और उतने समय में तो 4 कैटरेक्ट कर लेंगे. Medico-legal issues might be one of the reasons. और हम जहां भेज देते हैं इनको PMCH, NMCH, IGMS, वहां पे who are there in the emergency room to manage these cases? Our PGs, our residents. And what are they equipped with? I can talk about PMCH because I belong to it. No slit lamp, no microscope, no OT, nothing at all. करते क्या है फिर हम लोग? ऑइंटमेंट लगा के पैड एंड बैंडेज कर दो, एडमिट कर लो, नेक्स्ट डे एग्जामिनेशन होगा. और अगर संडे हो गया नेक्स्ट डे तो और लेट. समथिंग शुड बी डन रिगार्डिंग दिस प्रॉब्लम ऑल्सो. ये हमारी ही कमी है, हम कैसे करें, बट ये सिचुएशन है. I sincerely hope that all of us will be a little wiser after this seminar. Thank you.
Thanks, Dr. Ajay, for your nice word. And
these are all introspective words for all of us. And the thing which I said, that we should be keen to take up cases.
Yeah.
The prognosis
at least
of the cases
primary management should be given at least before referring to anything.
अगर इसको हम ज्यादा सिंप्लीफाई करें तो सबसे पहले पेशेंट को एग्जामिन करना और उसका जो ग्रीवियसनेस है उसको देखना, कहाँ कहाँ इंजरी हुआ है उसको फॉलो करना, और जो भी आप उस दिए गए सिचुएशन में आप कर सकते हैं वो करना. जरूरी नहीं है कि आप सब कुछ करिए. हो सकता है मेरा केवल ओपीडी ही हो जो शाम के टाइम चलता है, उस समय ओटी नहीं हो. तो जो भी हम कर सकते हैं और उसको फिर प्रॉपर टाइम पर या तो हम खुद लेंगे, अगर साधन नहीं है तो जो भी उचित जगह होगा वो वहां भेजना है. और ये भी मेडिको लीगल है, अगर आप सही समय पर सही जगह नहीं भेजते हैं तो आप नेग्लिजेंट माने जाते हैं. और मिनिमम जो आप कर सकते हैं उतना करने के बाद आपको भेजना. ये मेरा इसमें ऐड करना था. लेकिन सभी लोगों ने बहुत अच्छा प्रेजेंटेशन किया, बियॉन्ड एक्सपेक्टेशन. हम सोच रहे हैं कि आगे और भी लोग इसमें ज्वाइन करेंगे.
It was a very nice compilation and presentation. Good presentation.
All the PGs presented very well and the very part of it.
That's why we are discussing till 10 o'clock.
इतना इंटरेक्टिव सेशन कम होता है सर.
हाँ, we have already
इंटरेक्शन हुआ
more than half 5 minutes. तो अब के साथ हम खत्म करते हैं इस चीज को यहीं पे. और मैं रिक्वेस्ट
अगला
टॉपिक नेक्स्ट मंथ में करेंगे सर 10 के बाद
आराम से. लेकिन हाँ, करना, इसको रोकना नहीं है.
नहीं रोकना है.
कैरी ऑन विद
इंटर कॉलेज क्विज करना है सर.
अरे हम लोग
करना है, उसके लिए हेल्प चाहिए होगा.
पूरा ऑकुलर ट्रॉमा सीख लिए.
रिवीजन फॉर ऑल ऑफ अस.
तो मैं डॉक्टर सुधीर से रिक्वेस्ट करूंगा कि वो वोट ऑफ थैंक्स दें भाई. इन्हीं का टॉपिक था, इन्हीं का कंसेप्चुअलाइज था, किया हुआ और अरेंज किया हुआ सारा कुछ इनका.
सबसे पहले तो मैं प्रोफेसर सलील को सर कुछ बोल रहे थे सर.
हाँ, इसके पहले हम डॉक्टर सुधीर को कांग्रेचुलेट करते हैं कि इसका कॉन्सेप्ट जो है सो दिया. सो फ्रॉम बीओएस, ऑन बिहाफ ऑफ बीओएस एज अ प्रेसिडेंट, आई कांग्रेचुलेट यू.
थैंक यू सर. एक्चुअली प्रोफेसर सलील को मैं सबसे ज्यादा धन्यवाद देना चाहूंगा कि उन्होंने हमारे रिक्वेस्ट को एक्सेप्ट किया और उसमें बार बार होने वाले चेंज को भी एक्सेप्ट करते हुए अपने बिजी टाइम से समय निकाला। मैं फिर से उनको धन्यवाद देता हूं। और इसके साथ ही मैं स्पेशली डॉक्टर नंदन, डॉक्टर प्रगति, डॉक्टर फरहत, डॉक्टर आली और डॉक्टर श्रेया को मैं धन्यवाद देता हूं, जिन्होंने इतना पेन लिया और इस प्रेजेंटेशन को बनाने में और हम लोगों को समझाने में कि ये क्या चीज होता है। और इसके साथ ही मैं सभी मॉडरेटर्स और पैनलिस्ट को उनके इनपुट के लिए थैंक यू बोलता हूं। एंड आई एम ग्रेटफुल टू BOS and ARC BOS for the BOS members for allowing this topic. And I say thank to all the audience for the same reason, because they contributed and they were present and listening to the and giving and always giving their inputs. And last but not least, I say thank you to Astajon Ophthalmics for their support in the event. And again, thank you to all.
Thank you, sir.
So
Thank you so much, sir. Thank you.
for that is all for tonight. So we should leave now.
Bye bye.
Thank you, sir.
Thank you. Bye.
Bye. Good night, sir.
All the best.
Good night, everybody.
Thank you, sir.
Thank you.
Thank you, sir. Good night.